Hi everyone. Well, in this module, we would be discussing pathology, but as they say, in a rapid manner. So rapid review, as the word suggests, is number one going to be rapid. It's almost like if the earlier videos you've seen at a 2x speed, this is obviously inherently going to be at the original speed at a faster pace because that's the entire concept. It has to be rapid, and at the same time, it's going to be a review, which means it's not going to cover the depth of each and every topic in as much as depth as we have studied in our full syllabus or in our full videos. But definitely this is going to include all the important topics with all the high yielding and the PYQs that you need to know for the exam. So let's get going. I hope this is a fruitful journey for all of you, and let us begin with the very first chapter, that is cell injury. I'm going to start off with the first most important one-liners. What is the most common cause of cell injury? Why does it happen? And we all know when the oxygen concentration goes down, that is hypoxia. So the next question will be, why is the oxygen concentration going down? What is the most common cause of hypoxia? And that is when the blood supply is cut off. And what is that condition known as? So when the blood supply is cut off, that is ischemia, and that is why the oxygen levels will go down. When the oxygen levels go down, which is the cell which is most sensitive to hypoxia, which is going to die away very quickly? And those are going to be the neurons, or also going to be the brain tissue. So whatever you wish to call it, they give away basically within 2 to 4 or 3 to 5 minutes. They are going to give away when there is hypoxia. Whereas if they ask you which is the cell which is most resistant, the last man standing, and the answer to that is going to be the fibroblasts. So this is going to withstand even 30, 40, 60 minutes of hypoxia. So these are the first 4 one-liners that you had to know in the cell injury chapter, and the rest of the chapter is going to comprise of what? There are 2 types of injuries that you need to know. Number one, where everything can come back, that is reversible cell injury, and the second one is going to be irreversible cell injury. So I'm going to start with these, and then I'll go on to the deaths and the adaptations. So when I mean reversible cell injury, we all know there is a mechanism. You all know there is one flow chart that you have to know. Should we try and make one common flow chart for it? So let's say when I'm talking about reversible cell injury, all of you told me that the story starts off by a decrease in the oxygen. As soon as the oxygen goes down, which is the first organelle which says I give up, and that first organelle is going to be mitochondria. So there is a mitochondrial dysfunction that happens, and we all know mitochondria is the powerhouse of the cell. So if the mitochondria gives up, this means the ATP production is going to go down. So what is the previous year question? Which is the first change of cell injury? The first change of cell injury is a mitochondrial dysfunction, and because of this, the ATP production goes down, and now you know that there are 3 changes that are going to happen. So tell me, which is the pump which will stop working? The sodium potassium ATPase pump is going to fail. The sodium potassium ATPase pump is going to undergo a failure. So for understanding the failure, you have to know the normal. We all, I think, remember that the normal pump, remember a mnemonic called Nokia? What was Nokia? That sodium is going to go out and potassium is going to go in. So we say that there are 3 sodium which are going to go out. So sodium goes out, and there are 2 potassium that are going to come in. So potassium comes in. That is how we studied it as Nokia. Sodium out, potassium in. That is normal because that time ATP was there. Now I'm saying ATP is not there. This pump has failed. So now it's going to be opposite. Now 3 sodium are going to enter. Bilkul opposite hoga. Now 3 sodium will enter and 2 potassium are basically going to exit. And that means that because there are more of sodium inside, there is going to be a water influx. A very, very important thing that happens is water influx, also known as cellular swelling. Guys, cellular swelling. Why has cellular swelling happened? It has happened because of water. So I call it the hydropic change. Very, very important information. The cell is going to become big like a water balloon. So repeating, because of the failure of the sodium potassium ATPase pump, there is going to be a water influx and there is a hydropic change that happens. Now, as the cell will keep on becoming big, big, big like a water balloon, ultimately there will come a time that there is some breakage that will happen. Water balloon will also burst, na, holi pe. We play with water balloon also bursts, and that results in the formation of myelin figures. What are the questions on myelin figures that you're going to get? Myelin figure question number 1, what is it made up of? So it is made up of phospholipid, much more in amount than calcium. The primary concern is phospholipid over here. Little bit of calcium it has. Question number 2, which injury do you see it in? You see it in reversible injury also, and you see it in irreversible cell injury also. But please please note, in reversible injury, this process is just going to start, whereas in irreversible cell injury, this process is going to be much, much enhanced. So if there are 5 myelin figures in reversible cell injury, there will be 50 or 100 myelin figures in irreversible cell injury. So basically, this is seen as a part of both cell injuries. Finally, question 3, how does it look like under the microscope? We can all see there are some lamellated concretions that I'm noticing, and in these lamellated concretions, which microscope have I shown you? The black and white microscope of Path, electron microscopy. So these all had resulted because of the failure of the sodium potassium ATPase pump. There is big swollen balloon cells, cellular swelling, and there is myelin figure formation. Apart from that, what is the second thing or the second event that is going to take place? Please note, when there is no oxygen, hypoxia, which kind of glycolysis will occur? This is going to result in anaerobic glycolysis. Guys, what is the byproduct of anaerobic glycolysis? It is going to result in lactic acid production. Lactic acid means that the pH of the body is going to go down. When the pH of the body will go down, acidic ho gaya na, lactic acid means what is going to happen to the nucleus? There is nuclear chromatin clumping. That's the next change that is going to happen. There is nuclear chromatin clumping that I notice. The second change of cell injury. So now I realize that the pump has gone, the nucleus has also gone, only the proteins are left. What is the process that makes the protein? Coming to the third thing. So which organelle makes the protein? Isn't it the rough endoplasmic reticulum? You used to study this in your school days also, na? Rough endoplasmic reticulum makes protein. What makes it rough? Rough is made by ribosomes. So now I say that in cell injury, what happens is that the ribosomes detach. Now guys, if the ribosomes are going to detach, that basically means that the protein synthesis is going to go down, and that is your third change of reversible cell injury. So I've tried to make one common flashcard. So you will realize in this rapid review, most of the places I've got you tables. They've got a lot of information written in those tables. Here I did not write that information because I wanted to explain it to you first. But yeah, we're going to have a lot of these flashcards, one flashcard, full topic into it kind of thing, so that the bulk of your subject is reduced. So what happened in reversible cell injury? What are the 3 changes that happen? Number 1, the sodium potassium ATPase pump fails. So there is hydropic change. Along with that, there is formation of myelin figures. Question number 2 is that there is going to be anaerobic glycolysis. So because of the change in the pH, there is nuclear chromatin clumping. And number 3, because the ribosomes are going to detach, the protein synthesis decreases. That is reversible cell injury, because after reversible cell injury, gradually you go into irreversible cell injury. So now if someone asks you, what are the 2 defining moments of irreversible cell injury? All of you are going to say the M and M. What is M and M? The first M basically means when there is a severe membrane defect, or you can say some kind of a membrane damage, and the second one is going to be a mitochondrial damage. What did I say? M and M, membrane damage and mitochondrial damage. So pehle kya karenge? We will damage the membrane. Simple. Let me damage the membrane over here. As I damage the membrane, I realize membrane gone, the barrier is gone. There was a door, I've opened the door, everyone's gonna come inside. I realize the first one to come inside is calcium. Do you know what this calcium is going to do? This calcium will go and sit inside the organelle. Which organelle does calcium rush to always? Calcium, this yellow color wala calcium, goes and sits in the mitochondria. What is this known as? This is referred to as amorphous densities, or if you want to know the full name in your previous years, it is amorphous flocculent densities. Amorphous flocculent densities. What do you have to know about it? Please note, flocculent densities. I'll ask you 3 questions and you're sorted. Question number 1, what is it made up of? It is made up of calcium. Question number 2, which organelle are you seeing this inside? This is seen inside mitochondria. And question number 3, which injury am I in? I am now in irreversible cell injury. So where do you see this? You see this in irreversible cell injury. 3 very important points when it comes to this amorphous flocculent density. Calcium in the mitochondria in irreversible cell injury. Super duper important information that you have to know. On that note, this is not the only thing that calcium does. Calcium is also going to go and activate a lot of enzymes. And please note that as it will activate the enzymes, what are the usual enzymes activated? like phospholipase, proteases, nucleases. Take a lot of enzymes are activated, but I am interested in the nucleases. How are the nucleases going to act? That is what is of my concern. So please note that the nucleases cause certain nuclear changes. They break the nucleus of the cell. So what are the 3 steps? You guys have to know this in the exam. It is known as PKK. Pehle to you have to know the order. See, nucleus. Nucleus is something you got from your parents. It can't break like this overnight, na? It's a step-by-step process. So there is PKK. What is PKK? P stands for pycnosis. Look at this. The nucleus has become so dark and central. So we say there is a nuclear condensation, nuclear shrinkage and condensation that is going to happen. That is what is referred to as pycnosis. Coming to the next. Look at the next change that has happened, guys. The nucleus has broken into pieces. Finally, bomb blast has happened in the nucleus. I refer to it as karyorrhexis. That is known as karyorrhexis. Can I just put it up in simpler words? And that is going to be nuclear fragmentation. That is referred to as nuclear fragmentation. And finally, I have the last one, and that is known as the nucleus is gone. It says done. Story khatam. So what is that known as? Karyolysis. See, the word is only telling me lysis means the nucleus is gone. I don't see any nucleus inside this. So if they ask you what are the 3 nuclear changes that are going to occur, there is pycnosis, karyorrhexis, karyolysis. PKK. Pycnosis means first the nucleus becomes smaller, then karyorrhexis means it's a bomb blast, and then finally lysis means that it's gone. And that is when we say that the irreversible cell injury is done. So please remember, what were the 2 defining moments? It was MNM. One is membrane damage, one is mitochondria damage. Membrane damage I can see because of which calcium came in. Mitochondria damage also I can see because again calcium came in. So either of the 2 things are going to result in calcium entry, and it's going to be super bad. Calcium coming is super duper bad. That wraps up your story of irreversible cell injury. Going back after this, the next dreadful event is going to be the cell death. So let's get going with the cell deaths. The first one that you have over here is going to be necrosis. So necrosis, apoptosis, necroptosis, pyroptosis. These 4 are very, very important. I'm starting with necrosis. Do you guys remember what was the definition of necrosis? It's a cell death, but what is important is it's a pathological cell death, which means it will always happen with some or the other kind of a disease. Very important. And it is going to be associated with inflammation. There will always be an element of inflammation that is involved. So you will see something like neutrophils written, some other inflammatory cell written. Very important. So these 2 words don't miss out. Necrosis is pathological, matlab not physiological. It is never going to happen normally. And second, it is associated with inflammation. So let me tell you, what is the most common type of necrosis that we have? That is the coagulative necrosis. Question number 1, this is most common. Question number 2, you will always see this in solid organs. Look at the picture above. You see the picture of a kidney over here, and in this kidney is a solid organ. Na? Can you see this wedge-shaped structure? It's an infarct. It's a coagulative necrosis, an infarct that has happened. So it is seen in solid organs, like it is seen in the kidney. It is seen in the heart. It is seen in the liver. Let me tell you, heart is the most common organ. So you will get a history of a heart attack. My basic concept is all solid organs show you this. Question number 3, what is the mechanism of action? It is said to be the denaturation of proteins. This is a previous year question. The denaturation of proteins is the mechanism of action of coagulative necrosis. Question number 4, what do you see microscopically? So your first point is that the tissue architecture is preserved. Preserved means that everything is going to be just like the way, like a ghost. What is a ghost? You will say ghost is, ma'am, that I can see that white color sheet, that outline of a ghost in a Bollywood movie, but I can't see the face of a ghost. So this means broadly it's some kind of a human being architecture that I can see, but I can't see the details. That is why I say tissue architecture is preserved. Overall, I'm seeing some round structures, but I don't see what those structures have. So basically, these are known as ghost cells. These are referred to as ghost cells. So ghost cell ka definition, the outline is going to be preserved and the details are lost. The details are lost. That is what you understand by a ghost cell. And these are not 1 or 2 ghost cells. They are numerous ghost cells that you're seeing over here. All these pink color outlines. Guys, ghost cells being numerous means this is looking like ghosts, dead bodies, graveyard. Graveyard jaisa lag raha hai. That basically means that I am dealing with a tombstone appearance. I am dealing with a tombstone appearance. appearance. Repeating once again, this is the most common type of necrosis. You will see it in all kind of solid organs like kidney, liver and heart. Heart is very common. Denaturation of protein is its mechanism of action. Tissue architecture is preserved. You see ghost cells and tombstone appearance. Coagulative necrosis is done. Repeating once again, it is going to be seen in the solid organs, except it is not seen in two solid organs. So please note, now when I'll give you the example of the brain and the pancreas, of the brain and the pancreas, these are also solid organs, but they don't show you coagulative necrosis. They are going to show you liquefactive necrosis. And the other name for liquefactive necrosis is going to be colliquative necrosis, because the word is only telling me that liquid, something is going to get liquefied, and I can see that over here. There's a lot of liquid material. This is a section taken from the brain, as you all can see. This is the only picture of liquefactive necrosis that they have. This is a segment of the brain. So did you ever notice or try to ask me that why, ma'am, when all the solid organs were showing you coagulative, why these two are showing you liquefactive? Because these two are the organs which are very, very rich in hydrolytic enzymes. These are extremely rich in hydrolytic enzymes. So you have to know this, and that is what you know for brain and pancreas. So if you get a history of pancreatitis, or if you get a history of a stroke, this is the necrosis that you're going to see. And liquid, solid to liquid. So what do you say? Is the tissue architecture preserved? No, the tissue architecture is not preserved. The tissue architecture is not preserved, because now something is going to become liquidy over here. These two necrosis are done. Club the two. Coagulative or liquefactive ka mixture kar do. What are you going to get? The third one, which is the most common in our country, the mixture of coagulative necrosis and liquefactive necrosis, that is caseous necrosis. However, question 1, which is the more commoner necrosis? So C for C, coagulative necrosis is the more common one that you see in caseous. Question 2, what is the meaning of caseous necrosis? This everyone knows since first year of MBBS only. Caseous means cheesy. So you're going to see some cheesy white, nice cheesy white, and cheese is ruined for a lifetime, because cheesy material is what you see on a caseous necrosis. Okay, so now what are the conditions in which you're going to see them? Of course, in our country, the first thing coming to my mind is tuberculosis, but this is also seen in fungal infections. Please note, they will give you an example of a fungal infection, for example, histoplasmosis. They could also give you coccidioidomycosis. So all of these fungal infections is what they are going to mention. They all show you the presence of caseous necrosis, the cheesy appearance. Okay, on that note, before I move on to the next necrosis, do you want to try solving a question to see whether you're on the right track? Have a look at this. So this rapid review was just not me being about breathless and teaching you a lot of things in a very short manner, but also making you practice questions important. So here you have a 61-year-old female who presents with left-sided chest pain. I have started making a history in my mind, which is also radiating to the arm and the jaw. The pain has increased severely over the past 40 minutes. The patient is immediately rushed to the hospital. Cardiac enzymes are elevated is a very important history mentioned. Patient is admitted and started on thrombolytic therapy. However, on the 5th day of observation, the patient collapses and dies. What did you make this as a case of? Classical case of myocardial infarction. That means I'm dealing with a solid organ. They've asked me what is the necrosis that you'll see in the heart. I know the necrosis that we see in the heart or any solid organ is going to be the coagulative necrosis. So the answer becomes so simple over here. How they started off with the medicine question, how they've landed up doing a regular general path question. So coagulative done, liquefactive done, caseous done. Now I move on to the next one, and that is the fat necrosis. So please note, this is the easiest for me because it is to do with fat. So what are the examples that I'm going to get over here? Either I'm going to get the example of breast, because breast contains fat. So breast you will say, why is fat breaking down? Fat is dying because of trauma. Fat is dying because there is some injury, road traffic accident hua on the chest, there is an injury, some football hit on the chest. That kind of injury to the chest is going to break the fat. So fat breakdown, fat death will happen because of trauma. Second situation can be omentum. Why do you think in the omentum, GIT mein omentum mein, why is fat breaking down? This is due to pancreatitis. Why? Because in pancreatitis, which enzyme is released? In pancreatitis, there is an increase in lipase, and don't you think that lipase lipase is going to break the fat? Yes, so either it is seen in the breast or it is seen in the omentum. Why is fat breaking down? In the breast because of trauma, in the omentum because of pancreatitis. Whatever may be the situation, the fat that is going to break down is going to break down into fatty acid and calcium. And how does calcium look like? All of you know, this is taking you back to school days, that when fat will break down into fatty acid and when calcium will come and stick to it, calcium is going to look like a chalky white area. Calcium is going to look like a chalky white area. So simple, starting dekho, ending dekho. If I have to pick up a case of fat dying or fat necrosis, what areas am I going to pick up? I'm going to pick up these chalky white areas, and that is going to make all the sense over here. So remember, fat necrosis going to show you chalky white area. Sorted. The fourth necrosis is also done. Let's go on to the fifth one. What is the fifth one over here? Fibrinoid necrosis, one of the easiest, because whenever some antigen antibody complex formation will occur, fibrinoid necrosis will occur. We have learnt it in a very simple manner. All the three-letter things are going to be examples over here. So what is PAN? Polyarthritis nodosa. What is RHD? Rheumatic heart disease. Everyone knows from the cardiac chapter that rheumatic heart disease is going to show you something known as the Aschoff bodies, hai na? So they indirectly show you fibrinoid necrosis. So PAN, RHD, then you have an autoimmune disorder called SLE, then you have hypertension written as HTN, but which hypertension? It is usually malignant hypertension. So all these PAN, SLE, RHD, HTN, all these three letter things are going to show you fibrinoid necrosis. And the picture seen over here, if you know the organ, you know the disease. The organ is blood vessels. And I can see there is a band of pink color, fibrinoid necrosis, that I'm seeing over here. So now tell me something, that fibrinoid necrosis in a blood vessel makes it what disease? It makes it a case of polyarthritis nodosa. So the fifth necrosis is also done. Coming to the sixth and the seventh, whatever you studied up till now were all pathology diagnosis, were all pathology necrosis. Now I'm starting with diseases which are clinical. So here you have a case of gangrene. Gangrene is what? Gangrene is a clinical diagnosis. The clinician or the surgeon is going to tell me that, okay, this is a case of dry gangrene and this is a case of wet gangrene. You can see dry gangrene is everywhere, dry or wet. What you can see is it's a very blackish tissue which is foul smelling. That is the definition of gangrene. It is black, foul smelling tissue that has occurred. And dry gangrene and wet gangrene, I'll say, okay, let the surgeon use these terms, because for me, ye jo dry lag raha hai, this dry gangrene is nothing but coagulative necrosis, and this wet gangrene that you have is nothing but liquefactive necrosis. So coagulative necrosis and liquefactive necrosis are nothing but dry and wet. So kind of making sense na, dry is coagulative and wet is something liquidy. So liquidy matlab liquefactive necrosis. So basically I say gangrene is, this is a PYQ, way long back, 7-8 years ago it came. Gangrene is a clinical term, not a pathology term. Sorted. There's one more clinical term. There is something known as Zenker's degeneration. What do you mean by that? So firstly, again, pathologist ke liye it is nothing new. This is nothing but a type of coagulative necrosis. It is a type of coagulative necrosis. So why is it different? Because this is seen in typhoid patients, salmonella. Typhoid kya hota hai? Typhoid is a food poisoning, na? So you will say, ma'am, is Zenker's degeneration a food poisoning? No. It is seen in typhoid. It is a type of coagulative necrosis not occurring in the intestine. No, it has nothing to do with food poisoning. It is to do with skeletal muscle. This is a necrosis that has happened as a complication in the skeletal muscle, and two very important muscle groups that are affected are rectus abdominis and diaphragmatic muscle. It is rectus abdominis and diaphragmatic muscle. These are the two groups of muscle which are very commonly affected with Zenker. So these are the three PYQs of Zenker's that you've got. Number one, it is a type of coagulative necrosis. So it's nothing new for us. That's question 1. Question 2, it is seen in typhoid. And question 3, it is seen in organs like skeletal muscle. And that wraps up your entire discussion of necrosis. Let's see if you can do one more question quickly and see whether you were able to guess things well. Here you have a 45-year-old female who presents with complaints of being hit on the chest by a football. Is there a history of trauma to the chest? Yes. While she was passing by the garden 4 weeks back, so immediately when the ball hit her chest, there was tenderness, there was swelling, but over the weeks tenderness subsided. However, she now notices a lump in the areolar region which is firm to hard. So see, now a 45-year-old coming to me with a lump in the areolar region, I'm definitely going to think of cancer. So I have to do radiological investigations. They also show me calcium. But now when I look back, there is a history of trauma that is present. And there is calcium. Is this hinting me towards a necrosis? And that necrosis is referred to as the fat necrosis. I hope everyone's understood this. You were able to solve this question, because with that you have wrapped up your discussion of necrosis also. What is the next cell death that we are going to go to? We are going to start off with apoptosis. Are you ready for it? Because I'm going to tell you differences. I hope your rapid review is going well till now. When I talk about apoptosis, I think the definition that you have been taught since first day of MBBS they started. What is apoptosis? Apoptosis is known as programmed cell death. Everyone will remember it till we die. We know this. Programmed cell death. But now that definition has an update. This programmed cell death is said to be a caspase dependent programmed cell death. And does it have inflammation? No. That is what differentiates it from necrosis. Necrosis mein cell was rupturing. There was inflammation present, whereas apoptosis is not going to have any inflammation. It is a programmed cell death which is dependent on a lot of caspases. So now the first thing that you will ask me is this seen normally or in diseases or both? Because you had studied that necrosis jo hai, that is only seen in diseases like TB or heart attack or stroke or pancreatitis. Necrosis was only seen in diseases, means necrosis was only pathological, but apoptosis is both. Apoptosis is going to be pathological as well as physiological, means they will ask you name one example of physiological apoptosis, and that is known as organogenesis. It is referred to as organogenesis or embryogenesis. That mainly means that during normal cell fetal production, when the normal fetus is developing, embryo is developing, the normal organs are forming, like your 5 fingers have to form. If 5 fingers have to form, the tissue in between has to go gayab, na? If the 5 fingers would not separate, you will have syndactyly. So where is all the tissue in between, the webs wala tissue, where is it going? It's going away by apoptosis. So you realize that organogenesis or embryogenesis is a normal apoptosis that is happening. Whereas what is it about pathological apoptosis? They always ask you these 2 C bodies. So always listen to me carefully. Always remember there is something called Councilman bodies. And then there is something called civet bodies. These 2 bodies are seen in some diseases, so they are pathological. Councilman bodies, C for C, it is seen in viral hepatitis. Kaunsa wala viral hepatitis? It is seen most commonly with hepatitis C virus. So Councilman bodies are seen with hepatitis C virus, viral hepatitis. Whereas civet bodies are given a lot of other C names. They are known as colloid bodies. They are also referred to as the cytoid bodies. So a lot of C names have been given to them, and they are seen in a condition which is known as LP, lichen planus. So you guys, when you go back to lichen planus, do you remember the disease in dermatology that has Wickham's tribe, and it is planar, polygonal, plaques, papules, pruritic, yes, purple, that PP lesion in dermatology. I hope you all remember. When you go to dermatology, you will get this question, wo PP wala jo lesion hai, that is lichen planus, has a very important body known as the colloid or the civet or the cytoid bodies. So dekho, once again, if someone asks you what is Councilman bodies, it is apoptosis. What is civet body? It is apoptosis. It is a pathological apoptosis. I hope everyone's understood this. And coming back, this was nothing but a caspase dependent programmed cell death. So next question that they will ask you is, what is the mechanism of apoptosis and how are you fitting the caspases into it? So please remember, in the mechanism of apoptosis, we have 2 ways. First, you have to start apoptosis, initiate, and then you have to execute apoptosis. So what did I say? What are the 2 things that we are studying? You have to start apoptosis and then you have to execute it. So when I say that we are starting apoptosis, either you will start it from outside, extrinsic pathway, or you will start it from inside, that is intrinsic pathway. So repeating, either from outside or it is going to be from inside. तो कैसे याद करें? Please remember that we have something called caspases in this entire process. So for initiation, I have caspase 8, 9 and 10 in order. For caspase 8, 9 and 10 for initiation, and caspase 3, 6 and 7 we have for execution. First you please ratta lagao, mug it up. Caspase 8, 9, 10 for initiation, caspase 3, 6, 7 is going to be for execution. And please note, out of 8, 9 and 10, देखो the way you write extrinsic pathway sounds like 8 and 10. E for 8 and X for 10. So in the extrinsic pathway, caspase 8 and 10 are gonna be activated. In intrinsic, if you read it opposite, it sounds like 9. So caspase 9 is going to be activated. Repeating, caspase 8 and 10 in extrinsic and caspase 9 is going to be in intrinsic, whereas for execution it is going to be 3, 6 and 7. So did you notice what exactly is a caspase? This is a question that you get. What is casp, ASP and ASE? Very important. So question number 1, what is C for caspase is standing for? This means it has cysteine residues. Caspase has cysteine residues. Coming to the next, what is ASP? ASP is going to be aspartic acid. What about aspartic acid? So remember, ASE क्या है? ASE मतलब enzyme. So at the end of the day, caspase is an enzyme. Enzyme means it's going to break something. How is it going to break? It is going to break the tissue after it sees aspartic acid. So for example, if this hand of mine is a tissue, you say, ma'am, I see aspartic acid on this finger, I will break it here. Then I see aspartic acid on this finger, I will break it here. Then I see aspartic acid on this finger, I will break it here. So wherever it will see aspartic acid, break, break, break. That is how it works. So remember, question 1, C for cysteine residues, ASP for it breaks after aspartic acid, and ASE means it's an enzyme. So caspase 8, 9 and 10 for initiation, 3, 6 and 7 for execution. We are going to give 5 minutes and quickly revise the mechanism. So first, I'm starting with initiation and we are starting with the extrinsic pathway. So please note, extrinsic pathway means something is happening from the outside. So for example, this is the cell which has to undergo apoptosis. This cell is blessed with something called CD95 or FAS. Remember, CD95 was the molecule. And this is the cell that I've got from my system. Guys, remember, this is a T cell of your body. This is a CD8 T cell. And this has something called CD95 ligand or FAS ligand. It has CD95 ligand or FAS ligand. That is what it contains. So please remember, bahar, from outside the interaction is occurring. So this is an extrinsic pathway. When they will combine, there will be 2 more molecules of CD95 that will come. So now how many molecules of CD95 are there? There is going to be trimerization. There is a trimerization of CD95 that is going to occur. And as soon as they become a trio, they feel, oh, we have become so powerful. Let us get another very powerful molecule. They get something called FAD. Now they are going to attract a very big powerful molecule called FAD. And you know what FAD does for you? FAD is going to activate which caspases? Guys, you're in extrinsic pathway. Which caspase will you activate? FAD is going to convert procaspase 8 and 10, because extrinsic pathway hai, into caspase 8 and 10. That is important. So remember, this was outside. Let me ask you some questions. If I tell you to put it in the correct order, first there is a one-on-one interaction, CD95 and 95 ligand. So 95 and 95 ligand, one-on-one. Then CD95 says, nahi, mujhe trimer banana hai. So 3 of them are going to come. Dekho, first there was one-on-one interaction. Then there's going to be a trimerization that will happen. After the trimer is formed, they're going to get a big molecule called FAD, and procaspase 8 and 10 will be converted into caspase 8 and 10. So they extrinsic mein 8 and 10 have been activated, but is there any molecule which can stop this process? This process can be stopped by something called FLIP. So when we are asked what is FLIP, definitely you're going to tell me that FLIP is an anti-apoptotic molecule, because as I said, it can flip the story. It can stop all of this from happening. Which pathway was this? This was, guys, the very famous extrinsic pathway. Now we are still in initiation and I'm going on to the intrinsic pathway. What is it about intrinsic pathway that you have to know? Something is going to happen inside the cell. So for example, if this is a cell, I am saying some element of stress has come. So for example, there is a UV light, sunlight stress that has come into the cell. As soon as it comes into the cell, it is going to activate certain stress sensors. I call them like those fire alarms that, oh, they start ringing, that some stress has come. And what are those fire alarms? We have BIM, BID, BAD, Noxa, Puma. Like I said, learn it the same way because ek rhyme ban jata hai. There is a BIM, BID, BAD, Noxa and Puma. These fire alarms start ringing. What are they going to do? When they start ringing, they will say, we don't want stress. We don't want to keep any stressful cell in our body. Stress hatao, remove this cell. They are going to increase all of your pro-apoptotic molecules, and they are going to decrease all of your anti-apoptotic molecules. So what are they trying to do? They are trying to take you towards killing, towards apoptosis. That stress hai, cut the stress, remove the stress. So in the exam, they are going to ask you, what are all the pro-apoptotic molecules and what are all the anti-apoptotic molecules? So please note, pro-apoptotic mein I'll tell you a list and then I'll tell you one mnemonic. Okay, good deal. Pro-apoptotic mein we have P53, we have BAC, we have BAX, we have BCL-XS. Whereas anti-apoptotic, we have BCL2, MCL1 and BCL-XL. And how am I going to learn it? Anti-apoptotic means it is going to lower. Lower means L. All the LL containing things means you have BCL2, you have MCL1, you have BCL-XL. Repeating, BCL2, MCL1, BCL, not XS, XL. All these LL things are going to lower apoptosis. They are going to be anti-apoptotic. ठीक है, याद हो गया? So what have I done? And everything else that you have, P53, BAC, BAX, BCL-XS, they are all stimulating, they are pro-apoptotic. Okay, so now coming back, what are you doing? You are increasing all those pro-apoptotic molecules, you are decreasing all these anti-apoptotic molecules, as a result of which what is going to happen? You are going to send a signal to the, what is this organelle? This organelle is the mitochondria. You are going to send a signal to the mitochondria that please kill the cell, just kill the cell. So mitochondria says, wait, I will release two things and that will kill the cell. Number one is something known as SMAC and Diablo. SMAC and Diablo are going to kill the cells. Number two is going to be cytochrome C. But they ask you, how does cytochrome C kill the cell? Cytochrome C combines with something called APAF1. And together they are known as apoptosome. This is a previous year question. Keep noting all these PYQs that I'm telling you, it will help you. Cytochrome C is going to combine with APAF1 and they are going to together form an apoptosome. That apoptosome will finally convert the famous pro-caspase 9 into caspase 9, because if you remember, which pathway are you in? You are in the intrinsic pathway. In the intrinsic pathway, which is the caspase that you had to activate? 9. To kar diya na finally. The question that you'll get, what is apoptosome made up of? Apoptosome is made up of cytochrome C and APAF1. Together they are called as apoptosome and they are going to finally activate caspase number 9. And I realize that with this process, your initiation is done. The extrinsic is also done, wo CD95 wala pathway, and intrinsic is also done. Once initiation is done, 8, 9, 10, everything has been activated. Now it's a chain reaction. Now you're just going to do execution. So please remember, if caspase 8, 9 and 10 all have been activated, now they are going to go and activate caspase 3, 6 and 7, and that is what is execution. How simple. Now it's a chain reaction that has started. Execution is done. You're like, ma'am, is apoptosis over? No, one tiny little step is left. You know, initially you had such a big cell and such a big nucleus, and then you had, you know, chota ribosomes and endoplasmic reticulum and mitochondria. Is it so simple that suddenly I say caspase 8, 9, 10, 3, 6, 7 and sab gayab? No, na. What is going to happen is the cell is going to fall off in bits and pieces. There are going to be membrane bound organelles. There are going to be membrane bound organelles which are going to fall off. They might fall off with the nucleus, they might fall off without the nucleus. Both is possible. So for example, there's a piece which falls off like this, little bit without the nucleus. There is a piece that falls off like this with the nucleus. So it could be with the nucleus or without the nucleus. Both of those are possible, right? And please note that these are referred to as apoptotic bodies. Now imagine you have thousands of apoptotic bodies circulating. What are you going to say? These apoptotic bodies are then going to go and send a signal to the macrophages. These apoptotic bodies, they are going to go and send a signal to the macrophages that please, what is macrophage? Macrophage is a hungry cell, na, that please come and eat me and finish. Macrophage is going to cause phagocytosis and finally your cell is completely demolished. That is apoptosis. So now, is it so simple? How did the apoptosis send a signal? What is this signal that they are talking about? What signal? How did it call the macrophage that please come and eat me? That is known as a very important step called flipping of phosphatidylserine. Apoptotic bodies are going to do a flipping of phosphatidylserine, as a result of which there is a signal, PS likhte hain, phosphatidylserine is PS. You get a signal that okay, I will do flipping. So for example, if this is a cell, it will bring the phosphatidylserine outside. It has got the phosphatidylserine as a marker. It's put those signboards that, oh, phosphatidylserine is there. Macrophage says, okay, this means this cell has to be eaten. So if you will show phosphatidylserine, macrophage will come and eat you, and that is what they are doing. They started showing phosphatidylserine. Macrophage goes and eats it. Process is completed. Please remember, this is also known as, this step that I've just explained, that how the phosphatidylserine is flipped and how the macrophage goes and eats it. This process is also known as efferocytosis. This is also referred to as efferocytosis. This is also known as eat me signal. Getting the phosphatidylserine outside is nothing but the eat me signal, right? So you are giving a signal that, oh, phosphatidylserine, this means I have to go and eat it. So phosphatidylserine is an eat me signal. Very, very important. I hope everyone analyzed this, because apoptosis is done, and I'm going to give you a 30-second quick recap once again. Apoptosis was of two types, physiological as well as pathological. Pathological में दो C bodies you have to learn, Councilman and Kivett bodies. Now you talk about mechanism. First you start initiation, either it's by the extrinsic pathway where you activate 8 and 10 caspase, or it's by the intrinsic pathway where you activate 9. Once 8, 9, 10 is activated, you go and activate the 3, 6 and 7 caspases, means you've done execution. When execution is also done, you will realize that the cell will start breaking off into bits and pieces known as apoptotic bodies. How will you kill this apoptotic bodies? You will call, you will send a signal to whom? You will send a signal to the macrophages. How do you send a signal? You send an eat me signal. Flipping of phosphatidylserine happens, and that is also known as efferocytosis. Macrophage will come, will eat it, and the story is finished. If someone now asks you, what are you going to see under the microscope and what are going to be the markers? So please note, look at the nucleus of an apoptotic body. This is apoptosis. So there are 3 parts that you have to know. Very, very important. When they ask you what is the microscopic feature of apoptosis, the cell is going to become shorter. There is going to be cell shrinkage. The size is going to be smaller, but the colors are going to be very enhanced. There is going to be an extremely pink color cytoplasm that I notice. And there's an extremely blue color nucleus that I'm noticing, and this is important because do you see why is the nucleus extremely blue? Because this is due to NCC, nuclear chromatin condensation. Please note, this is due to nuclear chromatin condensation. Very, very important phenomena. The chromatin is condensed. Nuclear chromatin condensation, and that is what you can see on this electron microscopic picture. You can see jo black areas hai, these are the areas in which the nucleus has basically condensed. So repeating once again, if they ask you what is going to be the microscopic examination and what is going to be the hallmark of apoptosis, all of you will say it is nuclear chromatin condensation. That is the hallmark. If they ask you what is the marker is annexin 5. The marker is annexin 5, and please note there are certain other annexins also. So if the examiner says annexin A1, annexin 5, why will you not get confused? Because apoptosis is AP. AP means annexin penta. Annexin penta. So apoptosis will tell you annexin penta. And guys, where do you see annexin A1? वो भी बता दो. Annexin A1 is seen in hairy cell leukemia. It is seen in hairy cell leukemia. So hairy cell matlab A1. That is how I notice it over here. It is seen in hairy cell leukemia, whereas annexin penta is seen in apoptosis. Easy to learn. That is the marker. But what is the molecular marker? Molecular word means some CD95, na? Some CD marker matlab molecular. So CD95 is the marker that I use over here. Next, I need to know that is there any stain which is important? Yes, there is a staining procedure called the tunnel stain. Please note that tunnel stain is actually going to be positive or negative. Tunnel to yahi hota hai. Staining is always positive or negative. So if you get a positive tunnel stain, you are dealing with a case of which cell death? You are dealing with a case of apoptosis. And if you have a negative tunnel stain, this means you are dealing with a case of necrosis. And how are you going to learn it? Positive has PO, apoptosis has PO. Negative has NE, necrosis has NE. So it is negative in necrosis and positive in apoptosis. That is the tunnel staining. lastly, you have gel electrophoresis. Now, what is gel electrophoresis that you all have to know? Have a look at this very, very famous picture. This is DNA gel electrophoresis. This is the DNA totally intact of a normal person, not broken at all. This is a normal DNA. Here I see the DNA is broken into many, many lines. And what is this known as? This is known as the step ladder pattern. Where do you see the step ladder pattern? Most commonly it is seen in apoptosis. It can be seen in necrosis also. Can be seen, but most commonly it is seen in apoptosis. Coming to the next, what is this pattern known as? This is known as the smearing pattern. When I'm saying smearing pattern, this is something that you see in a case of necrosis. Repeating once again, if I ask you this step ladder pattern, this is obviously very, very obvious. So step ladder pattern most commonly seen in apoptosis, can be seen in necrosis too, whereas smearing pattern is seen most commonly in necrosis. So please remember this DNA gel electrophoresis, much expected question, very, very important. So if I ask you a question like this which says that the following gel electrophoresis pattern in patient B, in patient B means this patient, what is this pattern showing you? It is the step ladder pattern. What do you see it in? Necrosis, apoptosis, both or none? Come on, we would want to mark apoptosis, but there is an option of both present. And that is why my best answer over here shall obviously be both. Both matlab, it is going to be seen in both necrosis as well as apoptosis. If they would have told me to select only one thing, I would have selected apoptosis. But yahan pe both hai, so I will select both. So that wraps up your necrosis and apoptosis. What are you going to move on to next? Quickly, you will study the newer cell deaths. Under the newer cell deaths, I want to teach you necroptosis and pyroptosis. Let me start. When I say necroptosis, of course, this is going to be a combination of two things. It is a combination of necrosis as well as apoptosis. Now, when I say necrosis plus apoptosis, so little bit of necrosis it will have, little bit of apoptosis it will have. You guys have to tell me the definition. Do you know? Necroptosis is a kind of a programmed cell death. You'll say, ma'am, apoptosis was also a programmed cell death. Difference kya hai? This has nothing to do with caspase. This has nothing to do with caspase. It is a caspase independent programmed cell death. That's the word that you cannot miss in the paper. It is a caspase independent. I promise, I will not talk about caspase at all over here. What are the causes? This can also be physiological. This can also be pathological. Normal bhi hai, diseased bhi hai. So remember growth plate formation. When the growth plate of the body is forming, in growth plate formation, there is necroptosis, which is a normal growth plate. So in the bones is going to form in everyone. It's a normal physiological thing. But in pathological, please remember, this is now being associated with fatty liver. Fatty liver means steatohepatitis. This is also being associated with pancreatitis. So these are the diseases in which necroptosis is occurring. What is the last part that you have to know? Jaldi se mechanism bhi kar lo. You'll say, ma'am, kind of I know the mechanism. One thing that I know that I never can use in the mechanism is caspase. Never, ever. Listen to me a million times. Necrosis and apoptosis ka combo, that is necroptosis. You never, ever use caspases. So, what is the mechanism? 1, 2, 3, death. That is how my students who learned in previous lectures learn it. Necroptosis matlab 1, 2, 3, death. What is 1, 2, 3? The first thing is the binding of TNF with TNF receptor. That is the first step that happens. As soon as the TNF and TNF receptor bind, there is a trio formed. And that trio is RIP kinase 1, RIP kinase 3 and procaspase 8. And suddenly you're like, ma'am, abhi to you had said like promise, I will not use caspase and never ever will you use caspase, and you yourself are mentioning, but listen, I've kept my promise. I am not mentioning caspase. I am mentioning procaspase. Procaspase 8 can be used here. Caspase nahi hoga. Inactive is used, active is not used, caspase is not used. So I have kept a trio of RIP kinase 1, RIP kinase 3 and procaspase 8, and this is the Robbins 10th edition update. This is going to result in MLKL phosphorylation, and that is how finally the death is going to occur. So a simple question comes that which cell death shows you MLKL phosphorylation? It is necroptosis. 1, 2, 3 death. 1 matlab TNF receptor. Second, there is a trio called RIP kinase 1, 3 and procaspase 8. Finally, there is MLKL phosphorylation and the cell is going to die. This can occur normally like in case of growth plate formation. It can occur in diseases like fatty liver and pancreatitis. Done with necroptosis. The next cell death that you have is going to be pyroptosis. Then I'll make you practice questions. But what is pyroptosis telling you? Pyro. What is the meaning of the word pyro? Come on, pyro means fever, something, bacteria, virus, kuch hoga, some fever thing is gonna occur. Yes, this is actually associated with some kind of a bacteria. Very commonly in the paper, you will get questions of Salmonella, Shigella, these kind of bacteria. When the bacteria, so for example, I draw a bacteria over here. When this is a bacteria and this bacteria enters into the body, can you say that which is the receptor that is going to welcome it? Which receptor welcomes the bacteria? That is the question that you get. The NOD2 receptors. The NOD2 receptors are going to welcome and receive this bacteria. And you know what is going to happen after that? There is going to be activation of inflammasomes. There is activation of inflammation. Na? Bacteria aaya to inflammation. There is activation of inflammasome, and which caspases are going to come under this process of activation? Caspase 1, 4, 5, 11. Repeat with me 1 million times. 1, 4, 5, 11. That's an update. What are the caspases involved in pyroptosis? It is going to be 1, 4, 5, 11. So please note, out of these, all of them, karna kya hai? Ma'am, ultimately you wanted to do pyroptosis, you wanted to do a cell death. So all of them are definitely gonna go ahead and they are going to do a cell death. There is no doubt about it. But you had also promised me one more word and you said pyro, fever bhi hoga, pyrogen bhi hoga. So please note that this caspase 1 is going to go and activate interleukin 1. Caspase 1 will activate interleukin 1 and this in turn is going to result in fever also. So they ask you a simple question. What are the caspases that cause cell death? 1, 4, 5, 11. But which caspase causes fever? 1 for 1. Caspase 1 is going to activate interleukin 1 and that is going to cause fever. Because we all know na, interleukin 1 causes fever. And that wraps up your pyroptosis. Are you ready for some question? Let's do a question first on necroptosis. Let me ask you which of the following is incorrect about necroptosis. Incorrect pucha hai, theek hai. Is it a caspase independent programmed cell death? Bilkul correct. Does it use RIP kinase 1 and 3 complex? Bilkul correct. Does it have growth plate formation, physiological necroptosis? Correct. But tell me, does it have caspase 8? No, the rule was, I said na, never ever necroptosis mein never ever caspase 8 is never ever used. Procaspase 8 can be used, but caspase is not used, and that is the answer over here. Let's practice one more question and wrap up the cell deaths. Which of the following is incorrect about pyroptosis? Tell me. Pyroptosis, is it seen with bacteria like Salmonella, Shigella? Yes. Is caspase 1 required? Of course. Death ke liye, fever ke liye caspase 1 was required. Was interleukin 1 activated? Of course, fever was happening with interleukin 1 only. All of these are correct. Is toll-like receptor used? No, not toll-like receptor. In pyroptosis, which receptor is used? It is the NOD receptor which gets your question. That is what is going to be the answer over here. Everyone sorted with the cell deaths? We are done with the cell deaths. Now we can move on to the next topic, and that is going to be cellular adaptations. So what do you need to know about the cellular adaptations? You have basic adaptations: hypertrophy, hyperplasia, atrophy, metaplasia, dysplasia. For the time being, in this chapter, we will only revise these 4. Dysplasia will come in that cancer wala chapter. So abhi I will not go into dysplasia, okay? So let's begin. First, I'll take these 2 into account. What is hypertrophy versus hyperplasia? Please note, as you can see over here, hypertrophy will mean increase in the size of the cell, whereas hyperplasia is going to mean increase in the number of the cells. So repeating, size is trophy, plasia always means number. So they will ask you the mechanism. Size of the cell, what is the mechanism of action behind both of these? How does the size of the cell become bigger? Whenever there is an increase in some transcription factors. Which transcription factors? Unfortunately, guys, little bit ratta that you will have to do. It is going to be NF80, GATA and MEF2. It is NF80, GATA and MEF2. These are going to be the transcription factors. When the transcription factors become greater, there is going to be big mota size of the cell. Whereas how does the number increase? Of course, come on, number is going to increase by division, mitosis. One cell will divide to 2, 2 to 4, 4 to 8. So mitosis is going to result in, no one will ask you the mechanism of hyperplasia, it's understood. Hypertrophy ka mechanism is a previous year question. That is going to be because of an increase in the transcription factors. Mug it up as it is. So are there any common examples? Are there any examples which show you both hypertrophy and hyperplasia? Yes. So let me do the two combo examples. Very important. If they ask you pregnant uterus or they ask you gravid uterus, yes, you will say it is going to show me hypertrophy and hyperplasia both. But guys, more of what? It shows you more of trophy. So remember, gravid uterus, and what reward do you get from a gravid uterus? From a pregnant uterus, you get a reward, that is bacha, that is a kid. So the trophy that you get is a kid. That is how I have learnt it. So gravid uterus mein se you get a trophy, which is your kid. So that is why hypertrophy is more common. Whereas if they ask you what do you see during breast development, especially during the P wala phases, means whether a female is pregnant or whether there's a kid who just hit puberty. So you will say again, we see both hypertrophy and hyperplasia, but because there are so many P's involved in this story, there is going to be more of hyperplasia that you see over here. Simple na? Puberty, pregnancy, plasia. P, repeating, puberty, pregnancy, plasia. So they ideally show you both, but gravid uterus mein trophy milta hai kid, so hypertrophy is more, and breast during puberty, pregnancy, plasia is going to be more. These were common examples. What are the individual examples that you have to know? Only and only showing you hypertrophy. I think everyone is aware that bodybuilders में the skeletal muscle, the big muscles is hypertrophy, the size increases. Second, you also know that in case of any obstruction in the body, so not just obstruction, proximal to the obstruction, hypertrophy occurs. Proximal to the obstruction, there is going to be hypertrophy. So let's think of any obstruction. Let's give you the most common example. If in the urinary bladder there is a stone obstruction, if there is a stone obstruction, what is going to happen proximal to the obstruction in a urinary bladder? There will be hypertrophy. So simple, whenever there is some kind of obstruction, the remaining tissue adapts by hypertrophy. Next, what are the examples? These were examples only and only hypertrophy, like bodybuilders in obstruction. What are the examples of hyperplasia? One example in females and one example in males that you will be doing. When I talk about females, I think everyone is aware that because of estrogen, there is something known as endometrial hyperplasia. Yes, endometrial hyperplasia is due to which hormone? E for E. Endometrial hyperplasia is due to estrogen. So endometrial hyperplasia due to estrogen, very simple, but correlate this with gynecology. Endometrial hyperplasia can lead to endometrial cancer. That is the question that you're going to get. It can result in endometrial carcinoma type 1. Please note this. This same information you will study in your gynecology lectures. Coming to what in males? Endometrium female में था, तो males में there's going to be prostate. There is going to be nodular hyperplasia prostate. There is nodular hyperplasia prostate. So your question is, which hormone does nodular hyperplasia prostate? PYQ. It is not because of you. If you're answering testosterone, then no. Remember that testosterone first changes into something. Testosterone changes into DHT, dihydrotestosterone. By which enzyme? By an enzyme called 5-alpha reductase type 2. By an enzyme called 5-alpha reductase type 2, and this dihydrotestosterone then causes hyperplasia prostate. So what was the previous year question? What causes nodular hyperplasia prostate? Is it testosterone or is it dihydrotestosterone? So your answer is going to be dihydrotestosterone, and that is going to result in nodular hyperplasia prostate. Dhyan se sunna, don't mark testosterone in the paper, mark DHT. So guys, tell me the pharmacology integration. If you have to stop this or if you have to treat this, what is the drug that you're going to give? Enzyme ko treat karo, enzyme ko inhibit karo. So that drug is known as finasteride. So remember, finasteride is an inhibitor of 5-alpha reductase type 2. That is what you can give for the treatment of nodular hyperplasia prostate. So simple. For hyperplasia, one female example, that is endometrial hyperplasia because of E for the estrogen. One is nodular hyperplasia prostate because of dihydrotestosterone. Moving on to the next. When everything was increasing size, number, hyper tha. Now when there is a decrease in the size and a decrease in the number of the cells, that is what you're going to call as atrophy. So they ask you what is the mechanism of atrophy, and that is going to be the UPP. UPP matlab there is something known as ubiquitin proteasome pathway. The mechanism is going to be ubiquitin proteasome pathway. So think of all logical things, guys. There is no ratta in atrophy that you have to do. So for example, if you stop using an organ, disuse atrophy. You stop using an organ, like fracture hua, you stopped using your arm, so the muscles will undergo atrophy. So please remember, there is muscle atrophy following fracture, which is a very important example. They will always give you ye wala symbol. So if there's a fracture of the arm or forearm, you're not moving your arm. So don't you think cast lag gaya, POP cast lag gaya, you're not moving your arm. So this means now your muscles will undergo atrophy because you did not use them. Similarly, if someone doesn't have food, this means malnutrition is going to result in atrophy. Someone does not have blood supply, this means ischemic atrophy is going to occur when the blood supply is cut off. When the nerve supply is cut off, you will say then also, ma'am, there is a problem. There is going to be what? There is going to be denervation atrophy. So all in all, I realize that I need certain things for functioning. You don't give me food, you don't give me blood supply, you don't give me nerve supply, and my organs are going to start shrinking. So this is finally referred to as denervation atrophy. One last thing, in the endometrium, can there be atrophy? Yes, old age mein. Endometrial atrophy, of course, postmenopausal, that 55-year-old female, of course there is endometrial atrophy. Can this lead to cancer? Can cause endometrial cancer. Which type? Endometrial cancer type 2 can happen. So where did I teach you endometrial cancer type 1? So please note, guys, this is something that you definitely have to know, that when I'm dealing with endometrial hyperplasia versus endometrial atrophy, both of them have ability to cause endometrial cancer, but this is endometrial cancer type 1 which happens after hyperplasia, and this is endometrial cancer type 2 that occurs after hyperplasia. And which of them is having a worse prognosis for the patient? It is this situation. The endometrial atrophy leading to endometrial cancer is going to be worse for the patient. Very important point that you guys have to know in this. I hope everyone's okay. The same thing you will study in gynecology. Hyperplasia causes type 1 endometrial cancer, atrophy causes type 2 endometrial cancer. Atrophy causing cancer is the worst prognosis possible. So atrophy bhi ho gaya. What is the last adaptation that I can say your body has to show? Metaplasia, one of the most important ones that you have to know. So I hope by now you have understood that this review is rapid, but I hope you've also realized that this review is going to give you everything possible that is informative, that is going to be concise, and is going to help you solve all your PYQs, previous year topics, and high yielding topics are done. Okay, so now when we come to metaplasia, what is metaplasia? Basically, either one epithelium is going to change into another epithelium, that is one probability, or the other probability is that one mesenchymal tissue is going to change into another mesenchymal tissue. So either it's going to be epithelium to epithelium, or it's going to be mesenchymal to mesenchymal. So can we do some examples, and can you also see the arrows that I've made? Both way wala arrow. Why have I done that? Because remember, this is 100% reversible phenomena. Another PYQ hitting up your way. This is 100% reversible. Whatever I'm going to tell you can come back. PYQ number 1. PYQ number 2 is, how is it possible one epithelium squamous to columnar, columnar to squamous? ऐसे कैसे change हो रहा है? What is the mechanism involved? Mechanism of action, that is going to be reprogramming of the stem cells. The mechanism is going to be reprogramming of the stem cells. That is very important. So repeating once again, some stem cell was told you had to make squamous epithelium. Now you're saying no, change the tuition classes of that stem cell. Tell him he now doesn't have to make squamous epithelium, now he has to make columnar epithelium. So like we do updates of videos now, that now okay, Robbins has changed it, a concept change ho gaya. So I am giving you a reprogrammed, I'm giving you a new video, I'm giving you a new update. Like that, you are going to give tuition classes to the stem cells and tell him that earlier you you were making squamous epithelium, but now you have to make columnar epithelium. Like that, metaplasia happens. So let me ask you, if I ask you a simple question, what is the most common metaplasia that you're going to have in the body? So there are two questions. एक है most common metaplasia and second is your favorite metaplasia. Don't get confused between these two. So please note, when I ask you which is the most common metaplasia, and the answer to that is squamous metaplasia. And there's a very important part about the terminology that I want to share with all of you. So please note, under the squamous metaplasia, there's a very important question. This is what you see in the lungs. Lungs mein, which epithelium do we have? The lungs usually have the ciliated epithelium. However, I'm saying cilia are there in lungs. Now, however, I'm saying that if you're dealing with a patient who's a chronic smoker, he's been smoking since a very long time, or someone who has vitamin A derangements. When I say derangement, matlab excess of vitamin A can also cause a problem. Less of vitamin A, less and excess, both are a problem. The epithelium is then going to change into squamous epithelium. So tell me, why did you call it squamous metaplasia? Look at the end result. The terminology is made on the end result. So squamous metaplasia is because in the end I get squamous epithelium. That is the most common metaplasia, another PYQ in front of you. But what is your most favorite metaplasia? Your most favorite metaplasia is going to be the favorite Barrett's esophagus. So when I'm talking about Barrett's esophagus, please note that first you will have to tell me what is the normal esophageal epithelium. The normal esophagus has something known as squamous epithelium. And suddenly we will realize that this squamous epithelium is changing. Why is it changing? Because you're dealing with a case of gastroesophageal reflux disease, as a result of which there is an intestinal columnar epithelium that the body has ended up making. Intestinal columnar epithelium. Look at it, read it again and again. Intestinal columnar epithelium. What is it about? Because so much of acid reflux was happening. Why did you make intestinal epithelium? Because intestinal epithelium has all these round cells which are said to be the goblet cells. So please remember, if they ask you what is the hallmark of Barrett's esophagus, what is the hallmark of Barrett's esophagus? And that is going to be the goblet cells. And of course, you know the story of the goblet cells. There are going to be two more questions that I will ask you. What do the goblet cells contain? The goblet cells are going to contain acidic mucin. Goblet cells contain acidic mucin. And what is the special stain for acidic mucin? I think we all know acidic mucin is Alcian A for ANA. It is going to be Alcian blue positive. So remember, acidic mucin is going to be Alcian blue positive. Very, very important information. Let's do a recap. What is Barrett's esophagus? Normal esophagus is squamous epithelium. In the process of gastroesophageal reflux disease, that changes into intestinal columnar epithelium. Intestinal matlab it has a lot of these round goblet, wine goblet glasses kind of cells. What do those glasses of goblet contain? They contain acidic mucin. What is the special stain for acidic mucin? It is going to be Alcian blue. That wraps up your epithelial metaplasia. But one question must be coming to your mind, that why are you only and only talking about epithelium? What about mesenchymal? So here I go. The only mesenchymal metaplasia example, itna sara M hai na, mesenchymal metaplasia example is myositis ossificans, which basically means that the myo, that is muscle, is going to change into ossificans, that is bone. Common sense na, myositis ossificans, muscle will change to bone, and this usually occurs as a result of some trauma. This happens like in the legs, someone got hit, someone had a bike accident, road traffic accident, koi trauma hua, some fight he had, muscle changes to bone. Whatever may be the situation, either you're talking about the most common squamous metaplasia, or you're talking about your favorite Barrett's esophagus, or you're talking about mesenchymal metaplasia, that is myositis ossificans, the end result is that this is a 100% reversible process. So why don't you attempt one question quickly out here? Tell me this. What is the histopathological difference between Barrett's epithelium and the stomach epithelium? Barrett's ka you only tell me. Which kind of mucin did I just tell you? It is going to have acidic mucin. And what is the stain for acidic mucin? It is going to be Alcian blue. Pehle apna answer bana liya. Now just search for that answer. Acidic mucin, Alcian blue. Alkaline nahi hai. Okay, then neutral bhi nahi hai. Prussian blue and alkaline, all wrong words. Acidic, Alcian blue. Barrett's mucosa is acidic and stains Alcian blue positive. The first option is looking correct. So sometimes in the exam you make your own answer and then search in the options that where is my answer present. Acidic mucin, Alcian blue, and that wraps up all of your important cellular adaptations. What are we going to move on to next? The next topic that we have are all the intracellular accumulations. This topic we are going to wrap up in 15 minutes because there is going to be a table. We'll do the table, we'll do the relevant stains. It's got a lot of pigment, lipid, protein, glycogen, calcium, a lot of stains that you have to know, and we're going to quickly wrap it up. So now let's begin with the next part, and that is intracellular accumulations. Of course, you know that in this we are going to make a table of all the pigments, lipids, glycogen, proteins and everything, and we're going to do their respective stains. That is the most important part, hai na? So let's begin first with the pigments. Under pigments, I pick up the first one, and that is melanin. Now, where all is melanin present, guys? Some common sense things which I've already written, which everyone knows. Melanin is present in our hair, all pigments, so our hair, our eyes, our skin, all of that has melanin, hai na? That is present everywhere. No one will ask you this question. They will ask you where in the brain is melanin present. So in the brain, it is present in substantia nigra. It is present in the substantia nigra. Very, very important question that you get in anatomy also. Now, what are the special stains for melanin? So I think everyone remembers M for melanin, M for mason. But which mason? They'll have a lot of masons in the paper. Mason Fontana, mason trichrome, mason pentachrome, many sort of questions. So remember mason Fontana, tanning of the skin is what you will mark. Next stain of melanin, Schmoll. Schmoll is going to be mole jaisa na? Mole sounding is going to be for melanin. So Schmoll stain. Which enzyme can be used as a stain for melanin? So please remember, there is an enzyme known as dopa oxidase. Dekho, it sounds like an enzyme. So dopa oxidase is definitely for melanin. And which immunohistochemistries can be used? There is something known as HMB45 and S100, out of which HMB45 you will have to remember M for melanin. Very, very important immunohistochemistry. So repeating, you have M for Mason Fontana, Schmoll stain, the enzyme is dopa oxidase, and the immunohistochemistry is HMB45 and S100. So you have a picture over here. This is the stratum basale of the skin. You all know stratum basale of the skin shows you melanin pigment. And this black color stain that you have over here is the very famous Mason Fontana. So let me ask you the next stain now, the next pigment. One was melanin. The next one that you have is to do with hemosiderin. Dekho, hemo word means that whenever they will give you a history of hemorrhage, hematoma, something to do with some kind of a road traffic accident, that is exactly when this story will come up. Which pigment will come? Bleeding wala hemo story hoga. That is gonna be hemosiderin. What do you mean by the word sidero? What do you mean by the word sidero? Sidero basically means iron. So when I'm talking about iron, the stain that we have is either you call it the pearl stain or you call it the Prussian blue stain. So you can all see over here that there is a stain which has given this nice Prussian blue pearls color, and that is the answer that you have. Very, very important PYQ again that you have to know. Repeating once again. So pearls or Prussian blue staining is something that is going to come up over here whenever they give you any iron related history, iron overload, hemosiderosis, hemochromatosis, any iron related history, you're going to think of pearl stain. Coming to the next pigment that you have, the very famous lipofuscin. First and foremost, everyone, please break this into two words. Please break it into lipo and fuscin. Why do I say that? Because lipo will remind you that what is the special stain? Lipo matlab oil red O. The special stain is oil red O. And what is fuscin going to remind you? Fuscin will remind you of fast. It is acid fast. Means the stain for fast is what? It is going to be the Zn stain. So repeating, oil red O for fat and lipo word and fuscin ke liye fast. Stains rat liya. Now let's get into the concept. Lipofuscin is something that you will see in old age. You will always see an 83-year-old man, an 85-year-old man. So you will always get an old age wala history. This is also known as senile atrophy. Old age. Always remember this 83-year-old male history that you will get. Next, it is a wear and tear pigment. What happens at the age of 83? The person has a lot of wear and tear in the body. So there's going to be a history of wear and tear present. And next, why is there going to be so much of repair, so much of distress in the body, so much of wear and tear in the body? Because this is a telltale sign of free radical injury. This is a telltale sign of Free radical injury. So lots of free radical injury happens with age. Free radical injury leads to what? It leads to lipid peroxidation, and that is the reason that lipofuscin is formed. So they can also ask you, what is the mechanism behind lipofuscin formation? It is lipo word kahan se aaya? Because lipid peroxidation has occurred. How do I identify this? One very classical way of identifying this is the location. Have a look at this. If this blue color thing is the nucleus, can you all see that lipofuscin is brown color around the nucleus? It is always around the nucleus. Even if you look at it under an electron microscope, you can see that ye wala area is the nucleus and this is always around the nucleus. Remember, it is classically defined as a perinuclear pigment. Now let me complete the story. As soon as you get an 83-year-old man with a perinuclear pigment, there is nothing else that you will think of other than lipofuscin. Sorted? Shall we move on to one question based on it? Let's try. Find out the incorrect option about the pigment shown below. Pehle to pigment identify karo. What is the pigment? You will say, okay, this is the nucleus and we have something which is around the nucleus. So what is that? That is a perinuclear pigment that you have. And what is it going to be? Is it yellow-brown in color? Huh? Correct. This is seeming correct. It is yellow-brown in color. Is it due to lipid peroxidation, free radical injury, lipid peroxidation? Yes, because it is lipid related. Is it positive for oil red? Oh, bilkul theek, correct. Is it seen in infants? No, this is senile, 83-year-old man. This is the false statement and that is what they had asked me. They had asked me for the incorrect answer and I've got that answer over here. Sorted. Now you know how to solve questions on lipofuscin, everyone. Let's move on to the next. So you've done the most important pigments. There is one pigment that I want to add on to this story. So what all pigments have you done? Number one, you've done melanin, the skin wala pigment. Next, you've done hemosiderin, which is to do with the iron related, the hemorrhage related stuff. Next, you've done lipofuscin and the entire story about it. Now I'm going to add over here something known as copper, and in which, because there's no picture in it, there's only text that you have to know. So copper ke liye kaun sa wala hota hai? I had learned RRR. Remember we did a movie called RRR. Pehle to tell me, copper is increased in which disease, or copper is associated with which disease? Will the examiner give you a question? Examiner will give you a question of Wilson's disease. And RRR matlab the copper ends with an R and the name of the stains are going to begin with an R. That is rhodanine and rubianic acid. Repeating, rhodanine and rubianic acid. So let's go once again. When I say copper, you're going to say RRR, rhodanine, rubianic acid. Everyone, please make a big table over here. And what is that table that is going to be? Where do you study rhodamine? Very important. This is different. When I say rhodamine, देखो उसमें M आया है. M is the Mycobacterium TB. So if the examiner writes rhodanine, you're thinking of copper. And when the examiner writes rhodamine, M for M, rhodamine is something that is gonna come across to you in a case of Mycobacterium TB. Very important thing in microbiology. Okay? So pigments are done. Can we move forward? I'm going to jump on to glycogen. So tell me guys, what is the stain for glycogen, or where will you talk about glycogen? So remember, glycogen will be increased common sense in glycogen storage diseases, which no one will ask you such a common sense question. They will ask you where in diabetes is glycogen associated. So yaad rakho, diabetes mellitus mein, in the kidney there is a condition known as the Armani-Ebstein lesion. There's a condition known as the Armani-Ebstein lesion, and this Armani-Ebstein lesion is nothing but glycogen in the PCT. There is glycogen present where? Which part of the kidney? It is present in the PCT. Basically, it's a kidney problem and it occurs in diabetes. So in other words, diabetic nephropathy. So they will ask you, glycogen in the PCT is this fancy name, that is Armani-Ebstein lesion, and how will you stain this glycogen? So remember how I have learnt it is, glycogen sounds like girls. Girls ka favorite color? Tell me two characteristics about girls. Girls ka favorite color pink, and second characteristic, girls are usually more sensitive, है ना? तो pink color वाला stain pick up कर लो. What is the pink color वाला stain? It is PAS. So P for PAS, P for pink. It is a pink color stain. Second, this is diastase. sensitive. Please remember, past positive diastase sensitive is what you are going to pick out over here. So remember, glycogen for girls, they will ask you diastase resistant or diastase sensitive. You'll say glycogen is diastase sensitive. Girls are more sensitive and girls like pink color. So pink and sensitive yaad rakhna. Past and diastase sensitive for glycogen. Sorted. What is the next thing that we are going to move on to? We will go on to lipid. Lipid is our favorite. Fat, fatty liver and all of that. So when I talk about lipid, I've already answered the first question, which is the most common organ in which fat is going to go. It is going to be the liver, and that is what is going to result in fatty liver. Next question, what if lipid goes into the heart? So imagine this is the heart over here, and what if this is red color heart, primitive school time wala heart, and what if lipid goes into it? What if yellow fat goes into it? Will it start looking like a tiger? Yes. So this is known as the tigered or the tabby cat appearance. This is referred to as tigered or the tabby cat appearance. Moving on to the next. What if fat goes into the gallbladder? And you can see that on a picture. Can you see those yellow color dot? Hai na? Ye yellow color is nothing but this dot is nothing but cholesterol that has happened. All cholesterol. So this is what? Cholesterolosis of the gallbladder. This is known as cholesterolosis. As I say cholesterol, na, so cholesterolosis of the gallbladder, which is giving a strawberry appearance. So guys, this is the famous surgery question. This is strawberry gallbladder. So they will give you this picture. They will say, oh, this is strawberry gallbladder. Can you tell me one stain for it? For that you should know, na, ye jo yellow dot hai, that is cholesterol. Cholesterol means lipid. So now for all these conditions, what are the stains for lipid? So oil is fat only, na. Oil sounds like fat. So ye jo red wala stain hai that you have over here, this must be oil red O, because common sense, it's gonna give a reddish color. So oil red O is stain number 1. The stain number 2 is black. You can see the black color. This must be Sudan black B. In fact, guys, there is another stain which is known as Sudan 4, which gives an orange color. If you can learn this extra information, excellent. Otherwise, oil red O and Sudan black B, so you have to learn. That is for lipid, what you had to know. I hope everyone's understood. The last thing that we have is to do with calcium. What is it about calcium that you have to know? So basically, I will be telling you what are the different types of calcification first, and then we go to the calcium. So calcification happens when all in the body. So I think this is a second year question which everyone's understood, and you've seen it in the main videos also. That is dystrophic calcification and metastatic calcification. When I say D, to yaad rakho, in both of them, I have a rule. You can blame only one thing in life. You can't blame two people. You have to blame only one thing. So in dystrophic calcification, I will blame the tissue. Whereas in metastatic calcification, I will blame the blood calcium. So blame one person. So when I say dystrophic calcification, you will say D for dystrophic calcification, D for dead and degenerating tissue. D for dead and degenerating tissue. So as I said, there is D for dead, D for degenerating, D for. So kiska problem hai? The tissue is dead. The tissue is degenerating. Tissue ka problem hai. This means the serum calcium levels are gonna be normal. Normal serum calcium levels 9 to 11 है ना, तो 9 to 11 का serum calcium level is normal. On the other hand, in metastatic calcification, the tissue is normal. The tissue is having no problem, no death, no degeneration, nothing, totally normal. Who is at a problem? The serum calcium levels are problematic. They are elevated. Blame one thing. In dystrophic calcification, blame the tissue. Dead and degenerating tissue is there. In metastatic calcification, blame the calcium. There is too much of blood calcium that is present. You know what will happen? This blood calcium will be so much, this will go and deposit in different tissues. This will go and deposit in different tissues. So you will say, ma'am, tissues ka galti nahi tha. It was not the fault of the tissues. The tissues were totally normal. It's the fault of the blood calcium that is going and sitting in the tissues, and the most common organ in which it goes and sits is gonna be the lungs. The most common organ where it goes and sits are gonna be the lungs. So everyone's understood the pathophysiology. Should I tell you the examples? Let's do one example. So for example, when I'm talking about dystrophic calcification, think of dead things. Think of, say, probably a dead parasite. Dead word aa gaya na, so dead parasite. Or maybe some bacteria. Maybe you can think of something like TB. TB may be dead hoga. Then some degeneration like atherosclerosis, that will also have dead. So anything dead, degenerating, so dead parasite, dead bacteria, like TB, dead atherosclerosis, and two very important images. Those two important images are Monckeberg sclerosis and Samoma bodies. Let me show you these two pictures. Ye dekho. This is a picture of Monckeberg sclerosis. Remember, Monckeberg sclerosis is also known as CMD. I'll explain this word. What do you mean by CMD? Please note. C for calcific. I've already told you which calcification? Dystrophic calcification. So they will ask you, why is this happening? Nothing. Degeneration hai. Old age mein everyone is going to have this. It's a degenerative phenomena. The name only has degeneration in it. So which calcification will it be? Dystrophic calcification. And where is it occurring? Medial. Medial matlab in the tunica media of the blood vessel. So all of you can see a blood vessel over here, and all of you can visualize that there is, yes, some blue color material. This is all the calcification that I am talking about. So you've understood the word now, why I call it calcific medial degeneration. It is calcium which is depositing in old age in the tunica media. You call it Monckeberg sclerosis because it has the word degeneration. It is dystrophic. Sabko samajh ho gaya? This is simple. Now the last thing that I come down to is Samoma bodies. Samoma bodies is another picture which is like the most famous picture of pathology, where you see this onion skinning, round and round thing happening. This round and round onion skin pattern is referred to as Samoma body. And where all do you see Samoma body? Very simple. You will take PSM and you will put a square on it. You will call it PSM square. You will call it PSM square. So what is PSM square? So P for what? P for papillary carcinoma. Any papillary carcinoma of the body, guys. Papillary carcinoma, thyroid or brain or lungs or intestine or endometrium or ovary, kidney, any papillary carcinoma of the body is going to show you Samoma bodies. Coming to two tumors which are hormonally related, that is prolactinoma and somatostatinoma. So prolactinoma and somatostatinoma. Coming to the next, we have very important gynecology tumor, that is serous ovarian tumors. Very important. Serous ovarian tumors show you Samoma bodies. One tumor of the brain, that is meningioma, and one tumor of the lungs, and that is mesothelioma. So that is where you see the presence of Samoma bodies. Repeating, PSM square, that is papillary and prolactinoma, somatostatinoma and serous ovarian tumor, meningioma and mesothelioma, PPSSMM, as a round onion skinning, that is Samoma body, which falls under the classical dystrophic calcification. Now talking about metastatic calcification. So please remember, first and foremost, you need to know that this is affiliated with metastatic. Matlab there has to be an increase in the calcium levels. Think of all the things where calcium spike will happen. Hyperparathyroidism. Of course, in hyperparathyroidism, there is an increase in calcium spike. What else? There is going to be a very famous disease which all of us know, sarcoidosis. Yes, this is a question which has come so many times in NEET, FMG, INICET, all exams. Sarcoidosis has elevation of serum calcium. It's one of the blood tests that you do in sarcoidosis. Next, which vitamin do you think is going to be affiliated with it, guys? Socho. Vitamin D, because when vitamin D will increase, calcium will also increase. Common sense. Like this, there are many other syndromes. For example, milk alkali syndrome can also show. Again, very rare to see milk alkali syndrome nowadays. But certainly I know that, yeah, when there's an increase in or milk alkali wala hota, to calcium also increases, na? So the two main questions that I am expecting is most common cause hyperparathyroidism and second a case of sarcoidosis. So types of calcification are done. You are now just left with what are the different stains for calcium. So see guys, the way you write calcium, that is going to solve this. See the way you write calcium, it sounds like calcine. Easy. Calcium, calcine is a stain, common sense. Calcium sounds like K. It gives you that K wala sound. So there's going to be kosa, kala. So remember, von kosa gives what color to calcium? Von kosa is going to give a kala or a black color to calcium. It's going to give a kala or a black color to calcium. So kosa, kala, K for calcium, K for kosa. And what are the next two alphabets? Al for alizarin red S. Al is going to be for alizarin red S. How simple. So you can see the photo over here. This is alizarin red S because it's giving a red color. Common sense. So repeating, calcium, calcine, calcium, kosa, Al, alizarin. Stains yaad ho gaye. So simple. But now I'll ask you a question. If you have very little amount of calcium, minute quantities of calcium, then what will you do? Which stain will you use? You will use alizarin red S. How have we learnt it? We had studied that whenever I want to stain zara sa calcium, little bit calcium, zara sa calcium, minute quantity of calcium, use alizarin red S. So zara sa calcium, alizarin red S. Simple. Calcium is also sorted. One last thing that you have to know, which is a very important one-liner that you have in calcium. What is the first site of calcium deposition? Where does calcium deposit first? So the first site of calcium deposition is going to be the very famous mitochondria. Very, very famous. However, there's an exception. In the kidney, it does not deposit in the mitochondria. In the kidney, it deposits in the basement membrane. Repeating. Everywhere in the body, calcium will go and sit first in mitochondria, but in kidney, the first place that it will go and sit is going to be the basement membrane. I hope everyone is clear with intracellular accumulations, your glycogen, lipid, everything to do with pigments, calcium, everything is sorted, so that now we can move on to the next topic for all of you, and that is going to be autophagy. Autophagy means what? Break the term and you'll finalize. Auto means self, and phagy means eating. So either they are going to call it self-eating or they are going to call it cell cannibalism. Self-eating and cell cannibalism is what we see in autophagy. And please note that a Japanese scientist, as you can see over here, Sir Yoshinori Osumi, he got a Nobel Prize in 2016 for identifying all of this, all this self-eating mechanism. And all of you know that the conditions, the situation in which this is noted, some common sense conditions. Like for example, if someone is old, he will survive by eating his own, because nutrients are not there, too much in old age, you don't eat good amount of food and nutrition. So you survive by eating your own self. Similarly, if someone is suffering from a case of malnourishment, if it's a malnutrition ka case, then also. Thirdly, please remember, this is now being linked with a lot of neurodegenerative condition like Alzheimer's and Parkinson's disease. That is exactly what I want all of you to know, that these are the situations nowadays in which they are saying that autophagy is noted. So now they will ask you certain one-liners associated with autophagy, that as we are eating our own selves, what is the marker for autophagy? The marker for autophagy is LC3. When I say LC3, it is light chain 3. Okay? If you don't even want to learn the full form, chalega. Just learn marker is LC3. What is the most important gene? So gene is very simple. You break autophagy ATG. So what is the gene? It is most important is ATG1. The first one is the most important. Otherwise, there are many genes, ATG1, 5, 7, 10, so on. First wala is most important. Now, if I ask you, what are the diseases associated with ATG gene? What if ATG5 ka mutation someone has? That person is at a risk of tuberculosis. ATG5 gene mutation at a risk of TB. One question that I'm telling you for the higher institute exams, ATG16L mutation is associated with inflammatory bowel disease like Crohn's and ulcerative. ATG16L mutation with IBD, inflammatory bowel disease. But most important, 3 one-liners are in front of you. What is the marker? It is LC3. Question number 2, what is the most important gene? First one is the most important, that is ATG1. And the next question is, what are the diseases? If someone has ATG5 gene mutation, that person is going to have a risk of tuberculosis. Sorted for everyone. Shall we move forward? The next topic is, why are we getting old? Very, very interesting topic. Why are we getting old? What is the reason? Cellular aging. So why are we aging? What is the most common cause? Because we are having a lot of free radical injury. A lot of free radical injury is happening into the body, and that is why we are getting old. So firstly, I will come back to free radical injury, but other than free radical injury, what are the other causes? There's one very famous cause known as telomere shortening. Our telomeres are becoming short. That is why we are becoming old. And what do you think is happening to our insulin? Don't we know that as we age, our body stops responding to insulin? Don't we have insulin resistance as we are getting older? And yeah, that is a reason that we are getting older. It's not that we are getting old and then we are becoming insulin resistant. Ulta hai. We are becoming insulin resistant, and that is why we are aging. That is the real concept behind it. So please note, what are the three main reasons of why we are becoming old and buddha? That is because one, of course, is exams, because we give so much of mental stress to ourselves. That is the reason for a medico becoming prematurely old. But in otherwise non-medico population, it is primarily because of free radical injury, it is because of telomere shortening, and it is because of insulin resistance that we are getting old. Now note, out of these, first I'm focusing on telomere shortening. So what is telomere is the first question coming to your mind. Telomere is something which stands for TE. It is going to be present at the terminal ends of a chromosome. It is the terminal part of the chromosome, and it has a sequence of TTA triple G. It has a sequence of TT. One telomere matlab TTA triple G is one telomere. Okay? Now I will say that, for example, at birth, you had 1 million telomeres. Or chalo, let's take a smaller number, 1000. At birth, you had 1000 telomeres. Then 4 divisions, 10 divisions, 20 divisions. From 1000, the telomeres came down to, say, 800. Then few more divisions of your cell, 800, say 700. So can I say 1000, 800, 700, 500, 200, 0? That is how you're getting old. As you are aging, as your telomeres are shortening, you are becoming old and old and old. So remember that with each division of the cell, you are becoming old. Why? Because your telomeres are going to become shortened. There is going to be telomere shortening that will happen with each division. So can you prevent it? Can you prevent that short happening? Yes. God has also given an enzyme called telomerase, which is RDDP, RNA dependent DNA polymerase. Telomerase is going to be RNA dependent DNA polymerase, and that is going to be an enzyme which can prevent. So it will say, okay, you have 1000 telomeres, I will keep it 1000. Wo 1000 se 900, 800 nahi hoga, it will keep it 1000. So can I say, if someone was born with 1000 telomeres and still has 1000 telomeres, that means that person will remain Amar. He's going to remain alive and young forever. Can I say telomerase can be defined as an immortality gene? It can be defined as an immortality gene, which means that the person is going to live forever and ever and ever. Hai na? Okay, on that note, one more question that has come in the previous year is, how many times can a cell divide? What is the average number of cell divisions? So the average number of cell divisions, a lot of controversy around it. Some books mention 40 to 60, some mention 60 to 70. Let's go by 60 to 70. What is Hayflick limit? This is a previous year NEET as well as FMG. दोनों में ये question आया है. You need to know this. Hayflick limit, firstly the ratta is 60 to 70. It is the average number of cell divisions. So average means from the entire body you have found out what is the average number of times that a cell can divide, and that is the Hayflick limit. Okay? Now you say that, ma'am, this is sounding quite depressing. I don't want to become old. I want to live forever. I want to be very, very young. How should I prolong my lifespan, and how can I live for like 700, 800 years if possible? So then you are gonna have to increase something in your body, and that is sirtuin. So if you want to stay forever young, you will have to increase sirtuins. Three questions in the exam that come on sirtuin. Question number 1. How many genes does it have? So sirtuins are gonna have a total of, earlier they used to say 1 to 6, now they say 7 and above genes are known. So sirtuin have 7 genes, 1 to 7 genes. Pehle to these are the genes that God has given you, but you have to increase them. So sirtuins are sirt genes. Next, what exactly are those? If someone asks you that what exactly is it? It is a histone deacetylase. This was a recent NEET PG question. Hota kya hai? What is a sirtuin? It is going to be a histone deacetylase. And next, if they ask you what is the most important or what is the use of sirtuins, so sirtuins have used ABCD. Ye to matlab 4 or 5 times, so I have only seen in the last 7 years that this question has come. And that is A for, pehle to what am I asking you? What are the benefits of sirtuins? You will say, okay ma'am, the benefits of sirtuins are A, it is making me very, very young. It is helping in anti-aging. Next, it can also be used in the treatment of cancers. And next, it can also be used in the treatment of diabetes. Which kind of a drug? For example, let me say sirtuin is a drug. What kind of a drug do you use for the treatment of diabetes? That drug which will improve the insulin sensitivity. It is going to improve the insulin sensitivity, and that is why I can use it in the treatment of diabetes. That is all a part of the previous year questions that have come. Question number 1, how many genes? Cert 1 to 7. Question number 2, what is the enzyme activity that it has? Histone deacetylase. Question 3, what are the benefits? It is anti-aging, cancer treatment, diabetes treatment. That is going to be the benefits of it, as a result of which someone will become very, very young. So please remember, you will say, ma'am, now to I have to know how can I increase these sirtuins in the body. So I'll give you one good news, one bad news. Good news kya hai? You can have red wine. By having red wine, you will increase sirtuins. Bad news kya hai? That you will have to have less food. Calorie deficit. So basically, eat less and drink more. That is how we learn it. Okay, so eat less, calorie deficit, and drink more. That is, red wine consumption has been associated with an increase in sirtuins, and that will help you live and remain forever young. Okay, but you say that I am constantly being reminded of that movie Pa and that character of Amitabh Bachchan in the movie Pa, where there was progeria, where there was premature aging. Yes. What is premature aging? Becoming old very, very quickly. What is most common cause of premature aging? Exams. NEET, PG, FMG, INI, CET. Medical exams, MBBS, most common cause of premature aging. Jokes apart, premature aging is genuinely a major disease. Progeria. Progeria is not one disease. Progeria is an entire syndrome of diseases, progeroid syndromes. Okay? And progeria is of many types. I've got you the two most important ones. One is Werner's and one is Hutchinson-Gilford. So, sabse pehle, Werner's has an onset in adult age. It is adult progeria syndrome. So that movie character Pa did not have Werner's, which is the onset that happens in childhood. Hutchinson-Gilford syndrome is going to have a childhood onset. Guys, this is a case of Hutchinson-Gilford. Remember this character? The Pa movie character looked exactly like this. The Hutchinson-Gilford syndrome has an onset in a childhood and dies also very early. So that is the movie character had Hutchinson-Gilford syndrome. What is the defect? NEET, PG and FMG questions. The defect that you have in Werner syndrome, mug it up as it is. This has come twice over in the exam. It is DNA helicase defect. And what is the defect in Hutchinson-Gilford syndrome? It is LMNA gene. LMNA gene is going to be defective. What is LMNA? Lamin. It is a laminopathy. It is lamin A gene. Examiner is really mean at times. He asks you lamin A gene or lamin B gene or so on. So remember, lamin A gene. Lamin A gene is what is defective in Hutchinson-Gilford syndrome. All clear with it, everyone? So Werner may be jaldi old, Hutchinson may be jaldi old, but the defect is totally different. So now, if I ask you that what is the Werner syndrome defect known as? What is the defect over here? Werner was DNA helicase, na? That was a question that came in the previous NEET PG. Werner syndrome is a defect in DNA helicase. Versus if I ask you, what is the defect that you see in Hutchinson-Gilford progeria syndrome? Think of your answer first. Lamin A. Ma'am said lamin A, lamin A. Don't get confused. देखो options क्या है? Keratin A, B, lamin A, B. तो नहीं confuse होना. Ma'am had said simple. That it's a simple thing that you have to think of. Lamin A. So here you go, and that's the answer. ठीक है? But now another source of confusion. Werner versus Vermeer. Remember, Werner is going to be the progeria that I am talking about, the premature aging. Whereas as soon as you use the word Vermeer, M aa gaya, you will have to think of something called M. It is the other name of Menon syndrome. So repeating, Werner is progeria, Vermeer is mer, that is M for M. Menon syndrome. Don't get confused in the paper. But if you studied all of this and I ask you the first question that I asked you in this process, what is the most common cause of aging? You'll say, ma'am, you understood telomere, insulin, everything you've spoken about, but the most common cause of aging was free radical injuries. So quickly, can you make one table of free radical injuries for me and tell me what are free radicals? Bilkul, let's get on to that. So now they will ask you, what are free radicals? How are they formed? There are total 1, 2, 3. 3 free radicals are there. Let's make them, let's break them, and let's finish the chapter. How do they form? So remember, free radicals, which are also known as ROS, reactive oxygen species. They are also known as ROS, that is reactive oxygen species. They come from oxygen. So whenever we have oxygen, of course, we always have oxygen, but thanks to the air pollution, the AQI, the water pollution, and so many pollutions around us, we have poisons, we have chemicals, we have toxins, we have so much of things that we don't need around us, and they convert our oxygen into this free radical. So pehla free radical is superoxide. The first free radical that we have is superoxide. Now how will superoxide change? Superoxide is going to change in the presence of an enzyme called SOD. What is SOD? Superoxide dismutase. It will change into what? It will change into H2O2. H2O2 means hydrogen peroxide. It is going to change into H2O2, which is hydrogen peroxide. That is the second free radical. Hydrogen peroxide will then change into hydroxyl in the presence of what? It will change in the presence of the very famous iron. And I'm erasing this, guys. This you have to fill up on your own. Iron to sabko yaad rehta hai, but what form to what form? Remember, 2 plus changes to 3 plus. Remember, as you are changing H2O2, तो H2O2 से start करा तो Fe2 plus से start करना. 2 plus changes to 3 plus, and this reaction, only labeling this much of information. Please note, only labeling this much of reaction over here. What is the name of this reaction? Iron wala reaction. This iron wala reaction is the Fenton's reaction. So see, the name only has this. Fenton's is Fe. Fenton's is Fe. So that is going to be the iron wala reaction. And you also know what is changing to what? 2 plus is changing to 3 plus. So what were the three free radicals? The first one is superoxide. The second one is H2O2. The third one is O. And which of them is the most dangerous? O is the most dangerous. O matlab OH. O is like, oh my god. OH is like, oh my god. Means if they ask you which is the most potent out of these, you will say, oh my god is the most potent. OH, hydroxyl. OH matlab hydroxyl, and that is going to be the most potent. So tell me now, indirect question. So many free radicals are forming. Which pigment will they form? Which pigment is a telltale sign of free radical injury? So free radical injury means this will result in the formation of which pigment? Lipofuscin pigment. So this means damage ho raha hai, body is having a lot of damage. Do you want that? No. What has God given you? Protectors. God has given you some protective enzymes. Your damage is not gonna happen. So please note, what are the enzymes that God has given you because of which the damage will not happen? Firstly, let me write that statement once again. Tell me, what was the first free radical? It was superoxide. The next one was hydrogen peroxide. The next one was, oh my god, the most dangerous, that is hydroxyl. You know, there is an enzyme called catalase. Catalase can break H2O2. Catalase is going to break H2O2 into simple things, water, oxygen, harmless things. Catalase break kar dega. Good. Catalase is a good boy. Next, we have an enzyme called glutathione peroxidase. Glutathione peroxidase can break both. Glutathione peroxidase can break both H2O2 and hydroxyl. Glutathione peroxidase, very good boy. दोनों चीजें. So catalase तो good boy था because it was breaking H2O2. Glutathione peroxidase, very good boy because it can break both H2O2 and hydroxyl. But what about this superoxide? No one is breaking the superoxide. So then I say, kya kare? What should I do? How should I break it? I say, let's do indirect. Convert this into H2O2. Then H2O2 can be broken down by so many things. Who converts it into H2O2? Superoxide dismutase. So can I say that superoxide dismutase in a way is forming free radicals also? Superoxide dismutase is breaking also indirectly the free radicals. Dono kaam. Diplomatic, hypocritic person he is. Superoxide dismutase is forming also and breaking also. I hope you all remember. Let's do a medicine correlate. Do you all remember there is a disease because of superoxide dismutase 1 gene? SOD1 gene mutation. Kaun sa disease hota hai which Stephen Hawking also had? Amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis shows you the presence of SOD1 gene mutation. What is it in medicine that they ask you? Amyotrophic lateral sclerosis is an upper motor neuron disease or a lower motor neuron disease? My answer is both. It is an upper motor and a lower motor neuron disease. Very important question of medicine. And that is sorted for you. So with that, guys, I want all of you to finish off this chapter on this note and quickly give me the answer to this question. All of the following enzymes may contribute in generating free oxygen radicals, generating free oxygen radicals within neutrophils for killing the bacteria, except generating. So, does superoxide dismutase make? You'll say, ma'am, ye hypocrite tha. Make, break, dono. So, correct. Does Fenton's reaction make? Yes. NADPH oxidase, abhi to I have not studied, I don't know. Glutathione peroxidase, does that make new radicals? Does that generate new radicals, or is it like a very, very good boy and it breaks the radicals? Yes, that breaks. So, which of them is not involved in generating? Even if I don't know all the options, I know that glutathione peroxidase though was very, very good boy. It was not making radicals. It was breaking. It was going to cause a protection. It breaks H2O2 as well as hydroxyl. It was very, very good boy. So, that is the answer over here. Okay? And for those who are confused that the NADPH oxidase kya hai, just go to the next chapter, do phagocytosis. You will see that NADPH also makes free radicals. That is exactly coming up in the chapter of inflammation. On that note, we have wrapped up our entire discussion of the rapid review of cell injury. I hope you're finding it rapid and reviewable. That is the entire concept about it. So it should be rapid and should be a review. I hope we've managed to do that. So see you in the next chapter, rapid review, that is inflammation. Now let's begin with the next rapid review session of inflammation chapter. You know this is an important, very, very important rather chapter that we have in general pathology, and you know there are some salient features, too much of cramming up. We're going to revise all the mnemonics and all the flowcharts, tables and concepts that we've done in the main videos. We're going to concise all of that and make it into more palatable as a chapter, I hope, fingers crossed. On that note, let's begin. First, let's start with basics, the classification. What are the two types of classifications of inflammation that you have? Number one, you will classify inflammation on the basis of the type of the fluid. Have you ever had common cold? Of course, hai na? Common cold mein what do you have? You have a running nose, means which kind of inflammation do you have? You have catarrhal inflammation. Catarrhal inflammation means common cold. Common cold is what? Water and mucus. Water and mucus, and that is the common cold that you're going to consider. So basically the running nose that you have, water and mucus comes out, that is a fluid. So you're doing the classification on the type of the fluid, and that is known as catarrhal inflammation. Second, day-to-day life example. Have you ever had an abscess? Pus wala. So what is that pus known as? Pus is known as purulent inflammation. Pus is known as purulent inflammation. So when you are talking about abscess, purulent inflammation is something that you would be considering. Then I'll tell you two more inflammations which you might have not studied or might have not experienced yourself, but you definitely be doing so in your medical profession. Those are serous and fibrinous. When we say serous inflammation, it means it is very, very watery, just plain like water. And when I say fibrinous inflammation, that means it's very, very thready. Thready mainly again means that it's going to be stringy. So now when I say there's a case of rheumatic heart disease, you will always see that they say that rheumatic heart disease shows you serofibrinous pericarditis. Rheumatic heart disease shows you serofibrinous pericarditis, and that is something which is also known as the bread and butter appearance. The bread and butter appearance that you see, serofibrinous pericarditis. Very, very important for you to know in the exam, right? So these are the different types of inflammations that you have in case of fluid type. The classification on fluid type, because the next classification that I'm going to tell you is based on the duration, and you know this is everyone's favorite classification. It's the famous acute and chronic inflammation. So you know what they ask you in the paper? Dekho, this to everyone knows that acute inflammation basically means things are going to happen quickly. Chronic inflammation means things are going to happen slowly, delayed manner, but they ask you the different types of cells. So what are the cells of acute inflammation? The cells of acute inflammation are neutrophils. And what are the cells of chronic inflammation? These are going to be 3 cells, but you have to know the most important one. So the most important one is macrophage. But other than that, it is lymphocytes, macrophage, plasma cells. Repeating, lymphocytes, macrophage and plasma cells. However, macrophages are the most important cell of chronic inflammation. So repeating, cells of acute inflammation are neutrophils. Cells of chronic inflammation are going to be lymphocyte, macrophage and plasma cell. I am telling you a rule means I'm going to tell you an exception. So please remember, for acute inflammation, all the acute inflammations show you neutrophil except for typhoid fever, because typhoid is an acute inflammation but does not show you neutrophils. It shows you relative lymphocytosis. It shows you the presence of relative lymphocytosis. On the other hand, all the chronic inflammations are going to show you macrophage, lymphocyte, plasma cells, but there is one chronic inflammation that is known as chronic pseudomonas, and that is going to show you opposite. That is going to show you lots and lots of neutrophils. So dekho, everyone focus on the cross connection. Please note that when you're talking about typhoid is an acute inflammation, but it shows you a cell of chronic inflammation, that is lymphocyte. Similarly, chronic pseudomonas is a chronic inflammation, but it shows you the opposite cell. It shows you a neutrophil, the cell of acute inflammation. It's a cross connection that I've made. I hope you all will learn this very, very important PYQ that you have. On the basis of this, I am first starting with the review of acute inflammation, the events, the mediators and the diseases. Then I'll go on to the chronic inflammation and the granulomas. So starting with acute inflammation, we all know that in the process of acute inflammation, there are 4 vascular events and 7 cellular events on which the examiner gives me questions. Hai na? So first, let me start with the 4 vascular events, the blood vessel changes that happen in acute inflammation. We all know, let's start. If this is the blood vessel, the first thing that the blood vessel is going to do is narrow, constrict. So this means the first event shall be vasoconstriction. It is vasoconstriction. As I said, it is the first event and it is a reflex. Reflex means it is not by any histamine or any mediator. It is just that the body is trying to shut off the bleeding. Bleeding is happening, body is saying I'll shut it off. So the vessel will constrict. It's only for a few seconds. Please note that this happens to be a transient phenomenon. It is only and only for a few seconds. After that, the body says, let me open up the blood vessel. So what is the next step? The next step is vasodilation. You can see the blood vessel will open up, the blood flow will increase. So they ask you, who does this vasodilation? It is done by mediators called histamine and serotonin. From today onwards, remember, histamine and serotonin are brothers for life. They will always do everything together, okay? They are going to come from different parents. They are cousin brothers. They come from different parents, different cells, but then they work together forever. Okay? So that is what you need to know for the histamine serotonin. What are they doing? They are making the vessel broader. It is vasodilation. After this, the third step comes is increased vascular permeability. Guys, I'm going to elaborate on this in exactly a minute, but just learn it, mug it up, ratta. Increased vascular permeability is said to be the hallmark event of inflammation. It is the hallmark of acute inflammation. That is a previous year question that you'll have. Increased vascular permeability. Permeability means what? All the fluid will move out. Means the cells, the plasma, all of it is going to move out extracellularly. Fluid is going to go out. So for example, if this was your blood vessel, all these things are going to leak out. So there is going to be all of it over here, and this is known as exudate. This cells and plasma moving out is referred to as exudate. Very, very important point that you have in general path. This is the hallmark event. Imagine all the water, plasma, all the water part has gone out. This means what? This means the rest of the blood is going to become sluggish because all the plasma has been lost. All the plasma cells, everything has been lost out. Therefore, the blood supply or the blood flow, whatever blood is left behind, that blood is going to be slow, means there's going to be a slow blood flow, that is stasis. That completes your 4 vascular events. Jaldi se repeat with me because then I'm going to go into details. First and foremost, what happens? What is the first event? The first event is vasoconstriction. Who does that? No one. It's a reflex. Next event, blood vessel becomes big. It's a vasodilation. Who does that? Histamine, serotonin. Then everything is permeable. Everything is going to move out. The plasma, the cells, everything is going to move out as exudate. That is the hallmark of acute inflammation. And finally, whatever is left behind is going to become very, very slow and boring and stasis. These are the 4 events. But which of these was the hallmark? Increased vascular permeability is the hallmark. And for that, I'm going to give you guys a detailed analysis. How does this happen? Big question mark. How is increased vascular permeability happening? So what is the most common mechanism for increased vascular permeability. Remember, it is endothelial cell, we call it endothelial cell gaps. Matlab, gap kaise bana? If I, for example, these two fingers of mine are endothelial cells, how will a gap form? When they will contract. If I contract these two endothelial cells, to gap ho gaya. So either there is an element of contraction or there's an element of retraction. So ye dekho, this is a blood vessel and these are the endothelial cells. By now everyone knows what is the CD marker for an endothelial cell. Endothelial cell is CD34 positive. CD markers have started, okay? CD marker 34 positive. These endothelial cells say we will contract. So this moves in this direction, this moves in this direction. Kya bana yahan pe? There is a gap formed. So endothelial gap formation either by contraction or by retraction. Who is doing this? Who is making them contract? The cousin brothers. Who are the cousin brothers? Histamine and serotonin. So this process is done by cousin brothers, histamine and serotonin. And is this going to be a slow, boring process or a jaldi, quick process? Remember, these cousin brothers always do jaldi kaam. That means this is going to be an immediate transient response. This is going to be an immediate transient response. It's going to happen very quickly, and that's a PYQ again that you guys have. Repeating. Wait, what is going to happen? Endothelial cell contraction or retraction will happen. Question 2, who does it? Cousin brothers, histamine, serotonin. Question 3, what is the timing? Jaldi, quick, immediate and transient response. But this is not the only mechanism. There are 4-5 mechanisms that I'm going to tell you for increased vascular permeability. This is the first and the most common one. What is the second mechanism and the third mechanism? The second one is direct injury. Someone from outside is directly injuring the cells, or someone from inside is directly injuring the cells. Let me give you one example. So for example, from outside, think of yourself living the good life on a beach. You're doing sunbathing. So you spent 8 hours or 10 hours under the sun. One day that life will also come when your exams will be over and you'll be chilling and all of that. So imagine you step out. Do you have sunburn within 1 minute? No, na. Sunburn happens after many hours. So tell me that when a sunburn happens, is it like an immediate 2-second response or is it a delayed, dhire kind of a response? It's going to happen gradually. This is a delayed response. And tell me, you spent 10 hours under the sun. You had a sunburn. Ho gaya, start delay after 10 hours it has started. Now you come inside, indoors. Is your sunburn going to get okay within seconds? No. Healing will also happen dhire na. So it's a very dhire response. It's a delayed, prolonged response. It's going to take place very slowly. Starting is also very slow. Ending is also very slow. Delayed, prolonged response. Whereas this means something from outside, sunburn, sunlight has damaged. What from inside can damage? Maybe the person has some bacterial infection, sepsis. Bacteria are damaging. Bacteria though will act very quickly. Bacteria will act very quickly. That is going to be immediate. So starting is going to be very quick, but recovery, I will have to give antibiotics, 10-day course of antibiotics, then have to monitor the patient. So starting is very quick by the bacteria, but the recovery is going to take time. Immediate, sustained response. Immediate, sustained response. Okay? So now, what are the things that you have to know? Firstly, I told you for the cousin brothers, with the first mechanism, contraction, retraction. For the cousin brothers I've learned as a mnemonic, jaldi, immediate, transient, quick response. Now, what am I learning for these two? Remember, for sepsis you can learn as CIS. CIS means what? For sepsis, it is immediate and sustained response. I've given you the logic, I'm giving you mnemonics now. For sepsis, it is immediate, sustained, that is CIS. Whereas for delayed sunburn, who is going to have a sunburn, or basically who is going to have sunbathing? Who lives that kind of a life? Deepika Padukone. Deepika Padukone lives that kind of a life. So delayed and prolonged. Deepika Padukone. That is, think of Deepika Padukone and having a nice sunbathing and chilling life. So delayed, prolonged response. Okay? That is the next mechanism for increased vascular permeability. The third mechanism for increased vascular permeability, just ratta lagao, that is leukocyte mediated. So basically the WBCs can also cause injury. That's all that you have to know. What is the fourth and the fifth and the last mechanism? D and E means transcytosis and angiogenesis. Now, what do you mean by transcytosis? Trans means through. Something is going to go through, and cyto means cell. So this time something is going to go through and through the cell. How can something go through and through the cell? Ma'am, I can't walk through a door, na? I will have to open the door. If I'm not opening the door and I'm still getting out of the room, matlab there is a secret window. What is that secret window? That secret window is the vesiculovacuolar organelle. Remember, over there's a chota sa VV organelle that is going to form. Tiny little VV organelle will form, and through that the cells are going to escape. So there's a secret window that is created through which everything is going to move out, the vesiculovacuolar organelle. The next and the last mechanism is, so they tha transcytosis. The last mechanism is angiogenesis. What is angiogenesis? Angiogenesis refers to new blood vessel formation. Angiogenesis refers to new blood vessel formation. Anything new and babies are immature. So all the new blood vessels are gonna be immature. And immature means, look at the gaps. They have gaps between endothelial cells, means they are leaky channels. Everything is going to leak out of them. All the new baby blood vessels are immature. They are going to be leaky channels, and that is how the permeability is increased. So now, why did I take these two on the same slide? Because for both of them, the mediators are the same. Both of them are mediated by something called VEGF. And second, the head of the cousin brothers, that is histamine. Histamine and VEGF will cause both transcytosis also and angiogenesis also. A quick review, there are 5 mechanisms of increased vascular permeability. Increased vascular permeability, which was the hallmark. How does that happen? First and foremost, endothelial cell gap formation. Cousin brothers do it, jaldi they do it. That is immediate and transient response. Then that could occur because of leukocyte mediated injury. I just have to mug it up. Direct endothelial injury, which could be a sunburn Deepika Padukone, so delayed, prolonged, or it could be sepsis. Sepsis is cyst, so that is going to be immediate and sustained. Then we have 2 things, which is transcytosis through the cell, through that secret window, and that is going to be vesiculovacuolar organelle, or angiogenesis, which are new baby blood vessels, which are anyway leaky channels, and these two are mediated by VEGF and histamine. Vascular events sorted. That is what you had to do now. You had to do how many vascular events? 4 vascular events done. Feeling confident? Should we move on to the 7 cellular events? Ma'am, 7 hai, I need a mnemonic. I can't learn like this. 7 hai, matlab, how can my brain learn so much? Never mind. 7 ke liye you will learn MRAT-COP. Please remember, MRAT-COP are the 7 cellular events. Pehle to rat lo. Quickly learn their names. M for margination, R for rolling, A for adhesion, T for transmigration, then C for chemotaxis, O for opsonization, and P for phagocytosis. MRAT-COP. One by one we will start it. So now keep repeating MRAT-COP, MRAT-COP. What is the first event? The first event is the cells are gonna come at the margin. So here you have, look at this, how the cells, now what is this? What is this orientation? So ye kya hai? Neutrophils. And if this entire thing is a blood vessel, what is the lining of a blood vessel? Lining of a blood vessel is an endothelial cell. So can I say the neutrophils have come to the margin? Right? They've come right to the margin. So step number 1 is margination. After coming to the margin, what are they going to do? What are these neutrophils going to do after coming to the margin? They will start rolling. They will start rolling like this. So step number 2 is going to be rolling and weak adhesion. Little binding will happen, little rolling will occur. So tell me one thing, if a ball is rolling, does a football start rolling on its own? No, na? You have to kick the football, then it will start rolling. So it will roll and then it will stop, and then again you'll kick it, it will roll, it will stop. So you need some things which will keep kicking the cell, which will keep kicking the football. And who does this rolling? So MRAT-COP mein R, rolling is done by whom? Rolling is done by selectins. Rolling is done by selectins, and selectins are E, P and L. English Premier League. तो kick करना है football को नहीं, the cricket ball, English Premier League. So cricket ball is rolling, that is English Premier League. So you have E selectin, P selectin, L selectin. Where are they present? Look at their alphabets. Where is the L selectin present? You will say, ma'am, L for L. L selectin is on leukocyte. Matlab yahan. You can label it over here. L selectin is on the leukocyte. Okay, where is the E selectin present? E for E. E is going to be on the endothelium cell. So E selectin is present over here. endothelial cell. Where is P-selectin present? How do you say P? P bolo, P. It sounds like P-E-E, है ना? ऐसा sound हो रहा है P. तो मतलब P for P-selectin for platelets and E for endothelial cells. So again, what am I going to do? I'm going to mark the P-selectin also in the endothelial cell. So overall, what did you realize? All the selectins are on the endothelial cell. The only selectin which is present on the leukocyte is going to be L for L-selectin. That is a PYQ, which is the only selectin present on the leukocyte. Common sense, it's going to be the L-selectin. I've told you their locations. What do they bind to? The P and the E selectin, they bind to sialyl Lewis X that is present. The P and the E selectin, they are going to bind to sialyl Lewis X. Whereas the L-selectin, that binds to something known as glycam or madcam or CD34, whatever you want to call them, all of them are the same. So L-selectin binds to glycam or madcam or CD34. Let's do a repeat. First you did the location. Where is English Premier League present? E for E, L for L, P for P. Ho gaya. Now you should know P and E selectin bind to what? They bind to sialyl Lewis X, and L selectin is going to bind to what? Glycam, madcam and CD34. So your selectins are done. That means your margination is done, your rolling is done. What was the next step, guys? MRAT COP. Proper adhesion. पहले हो रहा था rolling and weak adhesion. Now comes the A. A मतलब proper adhesion. Cell will keep on rolling, 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 and there comes a time and cell says, "Bus, I am gonna stick over here. I am stuck here." Adhered, adhesion. Glue लगा दो, stick कर जाओ. That happens by integrins. Adhesion is taken care of by integrins. So please remember, integrins are of two types, beta 1 integrin, beta 2 integrin. अब देखो, how do you say beta 1? V वाला sound आता है ना, 1. तो everything is going to be V. Means, if I ask you beta 1 integrin, what is it also known as? You will say it is known as VLA. See, this is beta 1 integrin. Where is it present? On the neutrophil. ये beta 1 integrin है, and if I ask you what is the other name? The other name you will say that, ma'am, 1 में सब कुछ is going to be like VV वाला sound. So there is going to be VLA. And what will it bind to? To the endothelium, it will bind to VCAM. It will bind to VCAM. तो simple हो गया ना. Beta 1, which is known as VLA, will bind to VCAM. Whereas there is a beta 2. Beta 2 has two numbers. What are the two numbers? CD11 and CD18. So beta 2 में 2. It is going to have CD11 and CD18, and that is going to bind to ICAM1. So repeating once again. Adhesion के लिए what do you need? You need integrins. There are two integrins, beta 1, beta 2. दोनों neutrophil पर हैं. Beta 1 sounds like 1, so it is VLA and it will bind to VCAM. Beta 2 is going to have two numbers. What are those two numbers? They are known as CD11 and 18, and they are going to bind to ICAM1. Everyone, go back and tell me what are all the different things that you're going to know for ICAM in the entire 19 subjects. ICAM ka correlation. You need to know one thing in pathology, two things in microbiology. So remember, ICAM1, which integrin binds to? It is the binding of beta 1 integrin or beta 2? Beta 2 integrin. Okay. Two more things are going to bind to it. Do you know which malaria binds to it? Brain mein which malaria goes? Plasmodium falciparum. How does it go and cause problem in the brain? How does Plasmodium falciparum stick to the brain ka blood vessels? By ICAM1. And which virus is going to stick to ICAM1? It is rhinovirus. So please remember these. These are very important points. Repeating once again. It is the binding of the beta 2 integrin. It is the binding of Plasmodium falciparum in the brain. It is the binding of rhinovirus. Extremely important points about ICAM that you have. Coming back, adhesion is done. MRAT. Margination, rolling, adhesion ho gaya. What is the next step? The next step is the fourth one. T. Transmigration or diapedesis. Transmigration or diapedesis means it's time for the cell to migrate out. How can something migrate out? एक basement membrane भी तो होता है. You have to break ना. There is always gonna be a basement membrane everywhere. How can you just walk out? You will have to break the basement membrane like this. How do you break the basement membrane? This is by enzymes called matrix metalloproteinases. Have you studied about them in biochem also? है ना? What are these known as? These are referred to as matrix Metalloproteinases. What is the question that you get in biochemistry? Metallo means which metal do they need? They need zinc. Very important. So matrix metalloproteinases, that is how you are going to break the basement membrane, and after that the cell will come out. How will the cell come out? That is by a mediator called PCAM1 or CD31. That is by a mediator called PCAM1 or CD31. Very, very, very important point that you have. So, ho gaya, the cell has come out, transmigration has happened. Now what? MRAT. Now comes the C. So, C ke liye we are going to have chemotaxis. This means the cell has come out. What was this step? Transmigration. But after coming out, the cell has to go towards whom? The cell has to go towards the bacteria. There is some bacteria or some virus or some parasite or some godforsaken organism in my body which is creating all that problem. So the cell has to go to the bacteria. Which movement? Is it going in one direction, two direction, or more? One direction. So chemotaxis is unidirectional movement. That is the question that you get. What kind of a movement is it? It is a unidirectional movement that you have of the WBC to the bacteria. The WBC moving to the bacteria, that is chemotaxis. It is unidirectional. It is very, very important. Now, please note, it's not so easy. If you have to go towards one place, it's not going to be that easy. You need some people. Like, for example, you say that I'm very, very focused towards my exam. Now, you are focused. Either it's your focus, your own motivation, or someone is motivating you. Maybe I am helping you a little bit, taking little credit, but someone is going to be motivating you, hai na? So if this WBC is moving towards the bacteria, that has to be done by certain chemotactic agents. First, which is the only chemotactic agent which is exogenous? Exogenous means it is coming from outside the body, and that is the bacteria itself. The only exogenous agent which is going to pull. So imagine this bacteria is like a magnet. Bacteria is like pulling the WBC itself, but it's coming from outside the body. Na? Bacteria is coming from outside the body. So it is an exogenous chemotactic agent. What are the motivation factors that you are making? How are you going to attract the cell? By LIC. LIC means leukotriene B4, interleukin 8 and C5a. A wala molecules rakhna, because you are attracting the WBC. So keep the A wala molecules. Don't do C5b in the paper. For attraction, you will use the A wala molecules. I hope that's okay with everyone. Yes. So moving on, there is an exogenous and there is an endogenous chemotactic agent. MRAT, COP, chemotaxis done. What are you going to do next? Now you will say opsonization. So do you know, the almost coming towards the end. So chemotaxis was the 5th step. Now coming to the 6th step, and that is opsonization. What is opsonization? This bacteria says, I am gonna coat myself with something very, very tasty. I'm adding some spices on the food. I'm gonna make it some oregano and chili flakes I'm adding, and I'm gonna make it very, very tasty. So opsonization is coating of the bacteria. Opsonization is coating of the bacteria. So you will say that, ma'am, what is this oregano and chili flakes that you've added? What are opsonins exactly? I can't answer to the examiner oregano and chili flakes. Now, how are you making the bacteria so tasty? So first and foremost, to make the bacteria palatable or to make the bacteria tasty, I am adding some oregano and chili flakes, but they are not really oregano and chili flakes. Please remember, the most important opsonin, the salt in the food, is IgG. The most important opsonin is IgG. But if they twist the question and they ask you which is the most important complement opsonin, so the most important complement opsonin is C3b. So remember, jo bhi BB molecules hai na, they are badhiya khana. That is how I have learned it. All the AA molecules were for attraction. So C5a, 4a, 3a, all these are for attraction. But all the BBB molecules are going to make the food tasty, na? So they are going to be badhiya khana. For the bacteria to be badhiya khana, to be good and tasty, I'm going to use BB molecules, 3b, 4b, 5b. These are all the BB molecules, but they have asked you the most important. Most important is going to be 3b only. Okay? So remember, which is the most important food? How are you making? What is oregano to your food? IgG. The most important opsonin is IgG. And what is the most important complement opsonin that they will ask you? So if they ask you complement opsonin, it is C3b. You've made your food tasty. Why have you made it tasty? To eat it, na? So finally do the 7th step and finish it off, and that is phagocytosis. Kill it, eat it. Now you'll say, ma'am, for eating a bacteria, I will need oxygen or I might not eat oxygen. So either there is going to be oxygen dependent killing. There is one way that I will utilize oxygen. There is oxygen dependent killing. And second is oxygen independent killing. Do you know that they ask you questions more on oxygen dependent killing, and oxygen dependent killing will need one enzyme. What is the most important enzyme needed for oxygen dependent killing? NADPH oxidase. We need NADPH oxidase, which is PHOX, FOX gene. देखो कैसे निकाला जल्दी से. NADPH oxidase, PHNOX, which gene does it come from? FOX gene. Very, very simple. So please note, NADPH oxidase is going to kill your bacteria for you. Very, very important set of information. And this will utilize oxygen. It's an oxygen dependent killing. Do you know what is it also known as? This pathway is known as H2O2 MPO halide system. This is known as H2O2 MPO halide system, which means it needs H2O2, it needs MPO, that is myeloperoxidase, and it needs halide. Halide matlab, go back to your school days, chemistry, periodic table. What was halide? Halide was chloride and all, hai na? Chloride, bromide, iodide, that was halide family, na? So I'm using H2O2 MPO and chloride to kill the bacteria. So it's known as H2O2 MPO halide system. And which enzyme is initiating this? It is NADPH oxidase. So finally you say that, ma'am, I'm so happy that this MRAT COP mnemonic of mine is done. Let's do a repeat. When I'm talking about M for margination, then we have rolling. Rolling mein kya kara? Rolling is because of what? Rolling is because of selectins. Do you remember English Premier League? E-selectin, P-selectin, L-selectin. Adhesion is because of what? It is because of integrins. How many integrins? Beta 1 and beta 2. T is for transmigration. If you had to break the basement membrane, which enzyme were you using? Matrix metalloproteinase. And which is the molecule that you were using for transmigration? PCAM1 or CD31. Simple na? Chemotaxis. Chemotaxis is what movement? Unidirectional or bidirectional? It is unidirectional movement. Very, very good. Next is opsonization, which is done to make your bacteria very, very tasty. Which is the most important opsonin overall? It is IgG, but which is the most important complement opsonin that I was talking about? It is C3b. Finally comes the eating. The eating process, oxygen dependent wala is more important. Oxygen dependent wala is more important, and that is known as H2O2 MPO halide system. Very, very good. And this wraps up your entire cellular events, that is MRAT COP. I hope you've got confidence in this, because you did a killing called phagocytosis, I'm going to tell you one more killing, and that is NETs. वो अलग है. NETs is different, phagocytosis is different, and that is what I want to tell you the difference between these two. Please note that when we are talking about NETs, it is neutrophil extracellular traps. It is neutrophil extracellular traps means this is a kind of killing. When will you see it? You say, ma'am, I am confused. This is also killing. Phagocytosis is also killing. How does my body get to know that this time I have to do NETs wala killing, this time I have to do phagocytosis wala killing? I'll get confused now. So I'll say simple. Whenever you have some very severe infection like sepsis, then pick up NETs. NETs kab karoge? When you're in severe crisis. NETs. Does it remind you of net practice in cricket? In cricket, all the players do net practice. When do they start doing too much of net practice? When there is some severe crisis in their form. When their form is like totally gone, that is when they say that, oh, we are doing more of net practice nowadays because my form is not so good. I'm not making runs. Hai na? So net practice kab hota hai? Net practice happens when there is severe crisis, means sepsis has occurred. So what happens? Which cell is going to come to your rescue? Neutrophil will come. How is it going to do the killing? This is a neutrophil, and this neutrophil says that, wait, I am going to send all of my nuclear chromatin outside. Extracellular. Please remember, all of the nuclear chromatin is going to be sent extracellularly. All of the nuclear chromatin is sent extracellularly, and that is how the trap is formed and the killing occurs. So you know which amino acid is needed? PYQ. Ye sab karne ke liye, all the nucleus being sent out, which amino acid is needed? Very important question. It is arginine. Arginine is needed for this process of this entire killing. Very important previous year 2017 question it is. Amino acid is needed. Which amino acid? Arginine. So now imagine what a sacrifice. For killing your bacteria, virus, fungus and all, the neutrophil has given its nucleus. Nucleus gone, neutrophil has committed suicide for you, for your benefit. So what is NETs also known as? It is also referred to as beneficial suicide. It is also known as beneficial suicide. So repeating, what is NETs? NETs is a kind of killing, but difference क्या है? I hope you could all feel that NETs में कहाँ killing हो रहा है? NETs is the killing that is happening outside the cell. NETs is a kind of an extracellular killing. In phagocytosis, you were eating inside and killing the organism. Phagocytosis is a kind of intracellular killing. Very, very important. NETs is, name only has it, na, extracellular traps. So it is extracellular killing. Phagocytosis is phagocytosin. In matlab, it is an intracellular killing. Coming back, this is another picture of NETs that could come to you in your paper. Very, very important. Please note that in NETs, you are going to have this kind of a picture first, in which you will be able to see that there is an orange color nucleus and there is a green color cytoplasm. You don't have to learn the colors. Just try to orient. Kya nucleus hai, cytoplasm hai. Nucleus is what in color? Orange in color. In the next picture, I see all the orange color has gone out. Nucleus has gone out. So what is happening? Neutrophil extracellular traps is what is taking place over here. All the nucleus has gone out. Last time, which amino acid has helped in all the nucleus coming out? Say it aloud 3-4 times. Arginine, arginine, arginine. Very important. Very, very, very important question. And now you'll never forget because I have irritated you with this question. NETs ke liye which amino acid? Arginine is important. Done. So this finishes off NETs also. One more question that you have and this entire topic wraps up, and that is emperipolesis. Now what is emperipolesis? What do you have to know about emperipolesis? Totally different. ये कोई killing ही नहीं है. People believe it's a killing. No, it is not a killing. It is just a simple lazy process called cell in cell. Cell in cell matlab there is gonna be one very big cell and that will end up eating a small little cell. So there's going to be a huge cell and that will end up eating a chota cell. So cell in cell is nothing known as but emperipolesis. Where do I see it, ma'am? You see it in Mark. What is Mark? Mark is a lazy boy. What is lazy boy? Just go and sit inside someone else. Cell in cell. So what is Mark? M stands for myelodysplastic syndrome and myeloproliferative neoplasms. MDS, MPN. Myelodysplastic syndrome, myeloproliferative neoplasm. You've studied this under WBC chapter. A stands for autoimmune hepatitis, which was a previous year question. R stands for Rosai-Dorfman disease. R stands for Rosai-Dorfman disease. And C stands for a leukemia called CLL. C stands for CLL. So please note what is MDS, MPN, M से हो गया, A for autoimmune hepatitis, previous year question, Rosai-Dorfman and CLL. Mark is a lazy man, he just goes and sits inside another place, cell in cell, that is known as emperipolesis. Easy guys, very important. Going forward, I expect a question on Rosai-Dorfman disease showing emperipolesis. On that note, you have finished off all the acute inflammatory events and the related topics. So now let's correlate all of this information overload that we just had. Let's put it into all the diseases that we have in medicine. Let's wrap it up. So here we have 4 diseases for all of you. Very, very, very important for your exam. Get going on your toes. You have to mug it up on your fingertips. Okay, so on that note, leukocyte adhesion defect is what you're going to call it the first thing. When we say LAD, we have 4 types. So I've tried to make a table. Chota karna hai na, we have to make it concise. So I've tried to make a table, know the defect, know the clinical feature, khatam. That's it. So first you have, there are 3 types of LAD. What does LAD stand for? LAD stands for leukocyte adhesion defect. LAD stands for leukocyte adhesion defect. You'll say, okay ma'am, ye wo rolling adhesion, selectin, integrin, that story I'm coming to. So when I say LAD, it is LAD 1, 2 and 3 and the mnemonic is 1, 2 and 3. How easy? 1, 2 and 3. Matlab, when I say 1, I'm going to say there is an integrin defect. See, the way you write 1 is the same way you write integrin, na? The way you write 1 and I, so I and I, integrin defect. And which integrin is defect? Beta 2 is defective. In LAD 2, 2 for 2, flip the 2, you get an S. So this is going to be a Sialyl-Lewis X defect. This is a Sialyl-Lewis X defect. And 3 for 3, this is a firm T3 gene defect. This is a firm T3 defect. How simple guys, 1 for 1, so that is integrin, but beta 2 integrin. 2 ka S banaya, that is a sialyl Lewis X, and 3 ka 3, that is firm T3 defect. Defects are done. All of these, please remember, are autosomal recessive disorders, and all of them are gonna come to you with lots and lots of infections. The patient is gonna have lots of infections. So let's make our table like this. The patient is gonna have lots and lots of recurrent infections. But what is different about each one of them? Please note that first and foremost, if they say there is a delay in the umbilical cord shedding, now this word I tell students to read very carefully, delay in the umbilical cord shedding. The mother is saying that after birth the umbilical cord stump did not shed off for many weeks. That is GLAD1. If there is a very rare blood group that is found, that is Bombay blood group, that is LAD2. And if there is an element of bleeding that is going to be present, that is LAD3. So repeating, LAD1 is going to be umbilical cord problem, LAD2 is a Bombay blood group, LAD3 is going to be bleeding. तो अब थोड़ा सा ध्यान से पढ़ना. If they say there is a umbilical cord shedding problem, it's not falling off, that is LAD1. But if I change the question and I say there is umbilical cord bleeding, bleeding word aa gaya, bleeding from anywhere in the body, be it even the umbilical cord, bleeding has come, mark LAD3. Don't get confused. Okay? Now moving on to the next disease. LAD is done. Now we are going to the next disease, and that is Bruton's hypogammaglobulinemia, BBB, and the story is done. What did ma'am just say? BBB. B for Bruton's. Remember, this is a condition which is more commonly seen in boys. So B for boys. This is actually a B cell defect. So B for B cell defect. And what is defective in B cell? It is a BTK gene defect. It is going to be a BTK gene defect. So remember, B for Bruton, B for boys, B for B cell, B for BTK gene defect. Sorted. So now what is the next word? Hypogammaglobulinemia. Hypogammaglobulin. There's a decrease in immunoglobulin, especially IgG. Guys, IgG was most important oregano chili flakes. It was opsonin. If IgG is not there, there is going to be defective opsonization. Very important. So remember, LAD is done for all of us. BBB wala Bruton's disease is done for all of us. Now we move on to the next disorder, that is number 1, Shediac-Higashi syndrome. What is CHS? It stands for Shediac-Higashi syndrome, and the mnemonic for Shediac-Higashi is Shediac. First and foremost, please note, it is going to be a lysosomal trafficking gene defect. It is a list gene defect, and the patient is going to have Shediac. So do you know what is Shediac? Shediac stands for C for CNS or neurological problems. The child is going to have delayed milestones, neurological problem. HE for hemorrhage. There's going to be bleeding and platelet defects. DI for decreased immunity. Lots and lots of infections will happen, decreased immunity. A for albinism. This child is going to have silver hair. Imagine this word written in the paper, guys. If they say there is a person having silvery gray hair, and you know that we are talking about Shediac-Higashi, light color hair, eyebrows, eyelashes, skin, albinism. And lastly, the K. The K is going to sound like K, but it means that there are coarse granules. There are coarse cytoplasmic granules that are going to be seen in the neutrophils. Can you see these big dots? These big dots are going to be seen in the neutrophils. So repeating once again, C for CNS, HE for hemorrhage, DI for decreased immunity, A for albinism, and K for coarse cytoplasmic granules. So repeating once again, that is the mnemonic Shediac, and that is how I learn it. How simple. Lots of these things mentioned together. Silvery gray hair, bahut sara infections, Shediac. Answer, done. The last disease that you have is CGD. What is CGD? Chronic granulomatous disease. Now when I'm talking about CGD, that is chronic granulomatous disease, please note that this is going to be the defect in the most important enzyme of phagocytosis. That is NADPH oxidase is missing. What did I tell you for NADPH oxidase? pH and OX. You had to pick up the pH and OX. So if they ask you what is the gene that is defective, the gene that is defective is the FOX gene defect. And what kind of infections occur in these patients? They are usually suffering from catalase positive infections. Name some catalase positive organism. Staph aureus comes to your mind sabse pehle. Okay, Staph aureus. Name one fungus. Candida comes to your mind. So bar infections are of catalase positive organism. You're dealing with CGD. What is the screening test? The screening test, देखो CGD 3 alphabets, screening test NBT 3 alphabets, D for diagnostic test, that is DHR. Remember, if they write confirmatory or if they add diagnostic, it's the same thing. So now they will ask you which is the screening test, chota wala test, screening matlab chota wala test, and which is going to be the diagnostic test. So one simple way of learning it is diagnostic is DHR. DHR is the diagnostic test and chota wala test. So chota, what you must have seen on social media, all these very young teenage couples are referred to as nibba nibbi, na? So nibba nibbi chota couples. So the nibba nibbi test, the NBT. NBT actually doesn't mean nibba nibbi. Don't reveal this to anyone. For you guys, NBT is nitro blue tetrazolium testing. NBT is nitro blue tetrazolium testing, but for our purpose that NBT test abnormal hota hai, theek hai, but NBT is nibba nibbi test and that is chota wala test. It's a screening test. Whereas DHR, what is DHR? DHR stands for dihydrorhodamine and dihydrorhodamine is D for D. It is the diagnostic test for CGD. So remember CGD 3 alphabets, NBT 3 alphabets, DHR 3 alphabets. NBT is chota wala test, screening test. DHR is diagnostic, proper confirmatory test. What is the enzyme defect? NADPH, that is FOX gene is going to be defective. Which kind of infections? Patient will have catalase positive infections, and that wraps up all of your clinical disorders. Why don't you attempt some questions for me? Let's start. You have a very young child, 4-year-old male child who presents with recurrent infections. Okay, that is one thing. And there are with staph, strepto, peripheral smear shows neutrophilic leukocytosis, and there is a defect in neutrophilic rolling. Guys, think with all your mind. Neutrophilic rolling. Rolling was responsible for what? Rolling kiske saath tha? It was selectins. Selectins have a problem. Selectins or sialyl X has a problem. Means which LAD am I talking about? Sialyl X, S2 jaisa lagta hai. I'm talking about LAD2. LAD2 mein which Bombay blood group hona chahiye? Has the examiner mentioned that? The child is found to have a rare blood group called Bombay blood group. Oh yes, confirmed, 100% stamp it. It is a case of LAD2. Coming to the next question. Again, a tiny little 19-month-old child with lots and lots of infections. There is a defect in neutrophilic adhesion. Who does adhesion? Adhesion is done by integrin. Integrin ka problem matlab which kind of LAD I'm talking about? Integrin looks like I, so this must be LAD1. LAD1 means umbilical cord problem hona chahiye. There is a history of delayed umbilical cord stump shedding after birth. Stamp it. It's definitely a case of LAD2. LAD1, there is no doubt about it. Definitely LAD1. Let's practice the one last question that we have. There's a 4-year-old boy. Physician says large painful boil on the left knee. He has a history of repeated infections with Candida, staph, kuch common dikh raha hai? Candida, catalase positive. Staphylococcus, catalase positive. Klebsiella can also be catalase positive. Since the history of age of 14 months, catalase positive infections. Okay, in case you could not remember catalase positive organisms in the exam, nahi strike kara. Still, lab studies show an abnormal test from what? NBT, the nibba nibbi test, nitro blue tetrazolium test is problematic. NBT 3 alphabets. So the name of the disease is CGD 3 alphabets. Now they tell you which of the following defense mechanisms is a problem. CGD mein which enzyme deficiency do you see? NADPH oxidase, na? So what is your answer over here? Option D, that is NADPH oxidase is going to be deficient, and that is the answer. So sorted. You are done with all the clinical correlations and you are done with all the things related to acute inflammation, which makes all of you ready for the mediators of acute inflammation. So now let's begin with the mediators of inflammation. First, I'll give you a basic, quick classification, then I'll tell you the salient features. Works well? So first, let me tell you that mediators are coming from two sources of your body. They are either coming from some or the other cell, or they are coming from the plasma. They are plasma derived. Plasma derived are the easiest to learn because all the KK sounding ones are going to come up over there. Means that when I'm talking about the very, very famous clotting factors, complement system, kinin system. See, what did I say? All the KK things, the clotting, the complement and the kinin, all the K stuff comes under plasma-derived mediators. So what is coming under cell-derived? Now these cells say that there are two possibilities. Either I will keep the material prepared from beforehand, or I will make it as and when required. So either you have food already prepared and stocked up in your refrigerator, or you're going to make fresh food. One of the two situations, right? So the first thing is you have preformed. Preformed means you have food which is ready and packed in your refrigerator. There are 3 food items which are packed in our refrigerator always, and they include histamine, serotonin, and lysosomal enzymes. Repeating, histamine, serotonin, and lysosomal enzymes is the pre-packaged food kept in your refrigerator all the time. They are preformed. Now after this, see, you've learned all the KK things had gone into plasma derived. Histamine, serotonin, and lysosomal enzymes are preformed, and after this, whatever the examiner writes comes under newly synthesized. So now this means that all these things that you are talking about, be it the nitric oxide, the platelet activating factor, the chemokines, the cytokines, the arachidonic acid metabolites, all of these that you're talking about will come under the newly synthesized. Ho gaya simple? That all KK things are plasma derived. Histamine, serotonin, lysosomal are pre-packaged food, and after that whatever thing comes up is newly synthesized. So now let's get going. Let me start from these 3 first. Histamine, serotonin, lysosomal enzymes. In one table, I want to finish off this entire story. So please remember, histamine and serotonin, as I keep saying, histamine and serotonin are cousin brothers. Means they come from different parents, but they are best friends after that. They are best buddies. So what is the richest source of histamine? The richest source of histamine is a mast cell. And what is the richest source of serotonin? Either you can call it an enterochromaffin cell. So one of the richest sources is going to be enterochromaffin cell. Serotonin also comes a lot from the platelets. Yes, it comes from the platelets also. So 2 things. The histamine is going to come from mast cells, and serotonin comes from most richest source, enterochromaffin cell, followed by platelet. Before I tell you their function, guys, what is the stain for a mast cell, which is a previous year question? Previous year question, they ask you what is the special stain for mast cell or basophil, these purple color wala, that is going to be toluidine blue. Toluidine blue is the special stain for mast cells as well as for the basophils, mast cells or the basophils, very important. So coming back, so mast cells coming, kya aata usse? Histamine. And what comes from enterochromaffin cells? Serotonin is going to come. So now tell me one thing, what is the cousin brother pact that they have? We are going to do the same work. Means number 1, they dilate your vessels, that is vasodilation. Then I've also told you they do the hallmark work. What was the hallmark work? The increased vascular permeability. They also increase the permeability, but what do they do in the lungs? They cause asthma, na? So what are they going to do? They are going to do bronchoconstriction. So their activity in the lungs is going to be bronchoconstriction, hence they have a role to play in asthma. Very, very important. Okay, so histamine, serotonin done. Now I can move on to the next one, the lysosomal enzymes. Lysosomal enzymes actually come from these granules. You know, questions come on these granules. What are these granules? Primary, secondary, tertiary. They have some other names. How will I learn that? So dekho, primary. Primary means what? Number 1. Primary 1. First alphabet is A. So first alphabet is A means they are also known as azurophilic granules. Tertiary. Tertiary means what? Tertiary means 3. So what is the third alphabet? Third alphabet is C particles. So tertiary granules are known as C particles. And what is secondary? So as you say, S for S. So the secondary granules and the specific granules are the same. Has everyone learned the names? Let's do a very quick recap. The primary granules, first alphabet azurophilic. Tertiary granules are the third alphabet C particle. And secondary granules are the specific granules. Now you need to know which lysosomal enzymes will they release after you've done the names. So simple, I'll start from here. See, when you're saying tertiary granules are C particles, what are you going to do out of it? From the C, you will make a G. What did I say? From the C, if you make a G out of it, you will realize that, yeah, this is gelatinase. So C particles are going to release gelatinase. Easy ho gaya? Okay. Now, what do the secondary granules release? Very simple. Secondary are specific. They will release something specific. So, which collagenase do they release? They release the specific collagenase, because the name of the granules is only specific. Na? So, which kind of collagenase do they release? Specific type 4 collagenase. One more thing they release, lactoferrin. How will I learn this? Instead of lactoferrin, from today onwards, learn it as lactoferrin, so that you know that lactoferrin is going to come from the 2 wala secondary granule. granules. हो गया ना easy? Secondary granules, 2 words, so it's going to be lactoferrin, and specific, so it's going to release something specific, specific collagenase. Coming to the primary school mein, what did you learn? You learned ABCDE, and that's about it. What is ABCDE? Please note, it releases A for acid hydrolase, B for the bacteria killing myeloperoxidase, C for cathepsin, D for defensin, E for elastase. Let's do a repeat. It is going to have A for acid hydrolase, B for bacteria killing myeloperoxidase, C for cathepsin, D for defensin, E for elastase. So primary school mein I studied ABCDE and the situation is sorted. So your preformed mediators are done. Imagine histamine, serotonin and lysosomal enzyme khatam. How simple, how easy and concise it has become. But now you will ask me, what about the others? So let's get going. Let's go to this family. We'll make 2-3 tables and simplify this also. Let's start with newly synthesized mein nitric oxide and platelet activating factor. But before that, can you attempt one question for me? If I ask you, gelatinase is released by which of the following granules? So make your answer first. Gelatinase. Gelatinase was actually coming from that C. Means the C particles, ABC, tertiary wala C particles. What is your answer? How simple has life become? If you do that table well, you are very, very sorted. Ho gaya? Chalo, now let's move on to the newly synthesized. Under that, first I will talk about nitric oxide and PAF. Please note, nitric oxide in medicine is very famous because it is an anti-platelet aggregator molecule. It causes reversal of platelet aggregation. It is anti-platelet aggregation, and at the same time it is also going to cause vasodilation. So it's very useful in a lot of drug therapies in medicine, in hypertension and so on. Platelet activating factor, because वो platelet activate करता है, so obviously it's going to cause platelet aggregation. When it will activate the platelets, it will cause platelet aggregation. It can also cause vasoconstriction. So can you see they're almost opposites of each other? Platelet activating factor सब कुछ छोटा करेगा, aggregate the platelet. Vasoconstriction, platelet को aggregate करो, vessel को close करो. So platelet aggregation, vasoconstriction, that is what platelet activator does. Nitric oxide, open means platelets will not be aggregated, all well spread out. Vessel is not going to be constricted, it is opened, vasodilation. हो गया, these two are sorted. Now let's move on to the next family, cytokines and chemokines. So when I go to this table, nitric oxide done, then platelet activating factor done. Now I'll do chemokines and cytokines. So starting with the chemokines, I think everyone knows that chemokines are divided into this family, where the C refers to cysteine and X refers to any amino acid. Any other amino acid on this planet will be X. So pehle to I say CXC. Then X hata do, CC. Remove a C, single C. So what did I say? I said CXC. Then you said, okay ma'am, let's remove the X from here. When I remove the X, I'm left with CC. And after that CC, when I remove this one C also, I am going to be left with single C. Methodology learned CXC, CC and C. Why am I telling you to learn these three first? Because this is known as alpha chemokine, beta chemokine, gamma chemokine. This is alpha, beta, gamma, CXC, CC, C. What are their examples? What do? They attract cells. Remember CXC, the way you write CXC, you can make an 8 out of it. What is going to come under it? Interleukin 8 comes. And what is interleukin 8 going to attract? Interleukin 8 is going to attract the neutrophils. Interleukin 8 shall attract the neutrophils. Coming to the next, only C, single C. So the way you write C is the same way that you write L. C and L almost same lag raha hai, right? So what is going to come under it? Lymphotactin is going to come. Common sense. What will it attract? It will attract the lymphocytes. Very, very simple. Coming to the next, CC. Whenever you write email to someone, CC may you put all the miscellaneous people. All the miscellaneous people are put in copy to carbon copy. So CC may you put na, so all everything else comes in CC. Eotaxin, common sense. Eotaxin will attract whom? Eosinophils. MCP, common sense. It will attract whom? It will attract monocytes and macrophages. Rantes is going to attract the T cells. All these come under CC. So let's do a recap. Please remember CXC, X ka 8 bana, so interleukin 8. CC mein all the miscellaneous eotaxin, MCP, Rantes, everyone comes. Single C mein you have L, so lymphotactin will come. So these three are sorted. Now I'm left with the weird one. What is weird wala? Some weird structure is there. CX3C. Totally different from the others, and the example is also totally different and weird sounding, which I don't hear anywhere else in pathology. Fractalkine comes under CX3C. I hope that is okay, because your chemokines are sorted, which is not an easy table. Why don't you take a test of yourself? Can you tell me that CC includes which of the following chemokines? So let's try answering one by one. Lymphotactin. L to looks like C, so this is going to be just the C chemokine. Fractalkine, ये तो weird वाला था, that is CX3C. Interleukin 8 was that 8 that I made out of the X, so that is CXC. What is left for CC? For CC, my answer becomes eotaxin. Of course, CC mein what is going to come? Eotaxin is the answer over here. How simple? Done with chemokines. Shall we proceed and do cytokines? Tell me first, guys, what all comes under cytokines? You will say, ma'am, under cytokines we have a lot of interleukins. We have the TNF alpha and we have interferons. These are the three things that I'm going to talk about. Interleukins, TNF alpha and interferons. So tell me, question answer karte hain. Who causes, or what does TNF alpha cause? TNF alpha, A for appetite. NA matlab no food, NFA, no food appetite, no appetite. It decreases the appetite of a patient. There is going to be decrease in appetite. Also, this is very, very important in the pathogenesis of septic shock. Go to medicine, study septic shock, you will find it over there. So repeating, there is no food or appetite, so no appetite and septic shock. What else? What is the ones that cause fever? Which interleukin? Almost every interleukin, but interleukin 1 and TNF alpha are very famous for causing fever. So now finally you can learn TNF alpha, NA matlab no appetite and F for fever. That is what TNF alpha does. Okay? And which is the interleukin which causes fever? Most commonly interleukin 1. Next, which is the interleukin which can start and stop inflammation? Dono काम. It can do both work. Pro-inflammatory and anti-inflammatory. Basically, we are interleukins 4 and 6. Interleukin 4 and 6 can do both work. Start, stop, both. But which interleukin is only meant for stopping the work? Interleukin 10. So please remember, interleukin 10 is anti-inflammatory. That is how we learn it. Anti-inflammatory tells me that it only has anti-inflammatory action. Interleukin 10 is only anti-inflammatory. Other than interleukin 10, please also note that there is something known as TGF-beta. TGF-beta is also anti-inflammatory. It is very, very important for you to know. Let's move forward. Which interleukin causes T cell maturation? T. How does T look like? T looks like a 7. Na? So which interleukin is going to cause T cell maturation? Interleukin 7. Coming to eosinophil, E, A, B, C, D, E. Who causes eosinophil activation? Interleukin. It is going to be interleukin 5 because 5th is A, B, C, D, E. Who causes neutrophil attraction? That we've just now studied. Who causes neutrophil attraction, guys? Can you recall something? Interleukin 8 was attracting the neutrophils, and that is exactly what I'm going to write once again over here. So, एक table हो गया. Fever के लिए interleukin 1, TNF alpha, no appetite. Pro and anti-inflammatory 4 and 6. Only anti-inflammatory RAN 10, that is interleukin 10 and TGF-beta. T cell, T looks like 7, so interleukin 7. Eosinophil activation, E looks like 5, so E is 5 basically, A, B, C, D, E, so interleukin 5. And neutrophil recruitment, interleukin 8. Now, coming to the next. Which is the interleukin that regulates APRs? What is APRs? APRs are acute phase reactants. Acute phase reactants, and that is going to be interleukin 6. What is interleukin 6? So please remember, interleukin 6 is something which became very famous after COVID, and you understood na, that cytokine storm hua tha in COVID and interleukin 6 levels were going off the roof. Please note that when interleukin 6 levels increase, whenever interleukin 6 levels go up, two things can happen in my body. Some of the levels of APRs will increase along with it. Some APRs will decrease. So if you ask me, C-reactive protein increases, ferritin, hepcidin, haptoglobin, fibrinogen, procalcitonin, SAA, serum amyloid associated, all of these increase. How will I learn so much? Not possible. Itna lamba list, how is it possible? But you know na, that when someone has fever and infection, C-reactive protein, COVID maybe also it was increasing. COVID may patients were having more of ferritin and all these molecules, hai na? So these are increasing. What is increasing means that is a positive APR. But do you know some levels will decrease in your blood? What is going to decrease in your blood? Remember TAN, because they will ask you which of the following are negative APRs. So first you will say A for albumin, A for albumin, and after that T for a lot of T's, transferrin, transcortin, transthyretin. What did I say? And even for that matter, antithrombin 3 also. So please remember, transferrin, transcortin, transthyretin, all trans things are going to be negative. Albumin is going to be negative, and N of course for negative APR. So who will decide who will increase in the blood and who will decrease in the blood? Interleukin 6 is that deciding point, which says that I will decide whether you're going to increase in the blood or decrease in the blood. Everyone sorted? So what did I tell you? Interleukins and TNF alpha ka baat hoga, that we've done. Interferons is the last table that I have to know. How many interferons do we have? We have interferon alpha, beta and gamma. The two questions that come are, what are the sources of alpha, beta and gamma, and what are the functions of alpha, beta and gamma? So please note, for the sources there is a mnemonic LFT, means L for leukocytes. It very commonly, interferon alpha comes from leukocytes, especially leukocytes like macrophages. Then next we have F for fibroblasts. And finally, the T is for T helper 1 cell. CD4 T helper 1 cell releases interferon gamma. So remember, alpha, beta and gamma comes from leukocyte, fibroblast and T helper 1 LFT. But what do? What is their function? Their function is alpha, beta, gamma. Simple. A for A, B for B, G for G. That is why for the functions I have written alpha, beta, gamma. Remember, alpha is going to have antiviral properties. It is going to be antiviral. When I say beta is going to be used in the treatment of a brain disease. Which brain disease? Multiple sclerosis. It is used in the treatment of multiple sclerosis brain disease. And gamma is going to be useful for what? G for gamma, G for granuloma. It is useful for the formation of granuloma. Number one more granuloma thing. Number one, it makes a granuloma. Number two, it is used in the treatment of chronic granulomatous disease. Repeating, when I say A, it is antiviral. When I say beta, that is brain disease treatment, multiple sclerosis. And when I say G for granuloma formation and the treatment of chronic granulomatous disease. Where do they come from? Leukocyte, fibroblast, T helper 1 cell, that is LFT. How simple is this interferon table? This has come in micro, it has come in path. It is very, very important. On that note, you will realize that all of your mediators are almost done. The only newly synthesized mediator left now is the arachidonic acid metabolite, which you anyway study so many times. If you pick up your pharma, micro, medicine, path, biochem, everywhere this is going to come. So please note, firstly, arachidonic acid. When I talk about arachidonic acid, I think everyone knows from biochemistry, it's a 20 carbon compound. Yes, previous year question in biochem. Where does it come from? Arachidonic acid comes from phospholipids. How will you break the phospholipids? You will break the phospholipids by an enzyme called phospholipase A2. So phospholipase A2 and even phospholipase C, they are going to break phospholipids into arachidonic acid. 20 carbon compounds are formed. Now once the arachidonic acid form is ready, what is going to happen next? Either it will be acted upon by the COX pathway. COX matlab cyclooxygenase, or it will be acted upon by the LOX pathway, and LOX is going to be lipooxygenase. So either acted upon by cyclooxygenase or lipooxygenase. So let's get into these pathways. When it is acted upon by cyclooxygenase, it results in the formation of prostaglandins. Repeating, when arachidonic acid is acted upon by cyclooxygenase, it gets into the formation of prostaglandins. So what is the first prostaglandin that we have? We start the story from G2. From G2, the next prostaglandin formed is H2. From H2, you will say, ma'am, what about the previous alphabets? What happened to D2 and E2 and F2 alpha here? All previous alphabets have come. What about the next alphabet? The next alphabet is I2. That is also going to come. So now I realized that PGH2 is going to give rise to the whole spectrum. The whole spectrum will be affected. Means the previous numbers, alphabets, D2, E2, F2 alpha, the future alphabets will also come from here. So remember, PGD2 causes D for D, that is vasodilation. Okay? PGD2 dilation. PGE2 causes E matlab pain. It's gonna cause, the way you, when you have pain, what sound do you take out? You say E, ouch, E. So E is gonna be for pain, okay? And F2 alpha is a drug that you use in gynecology, obstetrics actually. What is that drug? Carboprost. Carboprost is PGF2 alpha, right? So D2, E2, F2 alpha I have done. So simple, D2 for dilation, E2 for E, pain, and carboprost, F for female. Female wala, F wala is carboprost. Simple, D, E, F. Now, the H also releases the next alphabet, that is I2, and it also releases thromboxane A2. So please note that PGI2 is known as prostacyclin and TXA2 is known as thromboxane A2. It is known as thromboxane A2. Please note they are opposites of each other. Means thromboxane A2 will cause aggregation. This causes platelet aggregation. It causes platelet aggregation. PGI2, I for inhibition. This is going to inhibit platelet aggregation. This is going to inhibit the platelet aggregation. How simple na? Thromboxane A2 causes aggregation. PGI2 inhibits the platelet aggregation. Very, very easy, isn't it? What else do you have to know now? So now when I'm saying that one of them is aggregating the platelets, that will only constrict the, sab kuch pass karna. So if this is aggregating the platelets, this is only going to do vasoconstriction. This is only going to do vasoconstriction. And what is not aggregating the platelets? What is letting the platelets open up? That is going to open up the blood vessel also. So that is going to result in vasodilation. How simple is that na? Jo close karega, sab kuch close. What will open? Open everything. That is just a way of learning. So thromboxane A2 is aggregation, gonna bring everything together, vessel constricted, platelets aggregated. Prostacyclin, that is PGI2, it inhibits platelet aggregation and it causes vasodilation. That is what finishes off the arachidonic acid COX pathway, and you all know that which is the drug which inhibits both COX1 and COX2. Those are going to be NSAIDs and aspirin. NSAIDs, aspirin are the ones which inhibit both COX1 and COX2, but now we prefer selective COX2 inhibitors. We prefer selective COX2 inhibitors like celecoxib and all the other coxib family members. They selectively inhibit only and only COX2, but aspirin inhibits both. Aspirin inhibits both COX1 and COX2. So this pathway is done. The cyclooxygenase pathway is done. Now we are just left with the lipooxygenase pathway. What is the lipooxygenase pathway? Please note over here, very, very important, that this arachidonic acid can also take the lipooxygenase pathway and result in the formation of two things. Dekho, there is something called a 5-LOX and then there is something known as a 12-LOX. If it takes the 5-LOX pathway, it is going to form leukotrienes. Kaun sa leukotrienes? A, B, C, D, E. How simple? Leukotriene A4. A4 will give rise to leukotriene B4. And I think if you remember correctly, leukotriene B4 was a part of that LIC mnemonic. It was responsible for chemotaxis, hai na? And other than that, CDNE, it will give rise to C4, D4, E4, and these are the ones which cause asthma. These are the ones which are responsible for bronchoconstriction. So guys, tell me, if you want to treat a patient of asthma, what are the drugs that you will give? Now you understand, for the treatment, we give leukotriene receptor antagonist. We give leukotriene receptor antagonist. Can you name a few? They are montelukast, zafirlukast, all those leucast drugs. Montelukast, zafirlukast, they are all these. Inko inhibit karenge. They will not let them work because I know these are the people causing asthma. They are the culprits for asthma. So chuck them. Don't let them work. Leukotriene receptor antagonist though. Montelukast, that is what is its mechanism of action. So leukotrienes are done. A4, B4, C4, D4, E4, A, B, C, D, E. Simple. They were formed from 5-LOX. But there's also something called 12-LOX. 12-LOX makes lipoxins, and please remember, lipoxins are a stop. Means they are anti-inflammatory. Lipoxins are anti-inflammatory, and that wraps up your entire arachidonic acid pathway. So remember, the COX pathway is also done, the LOX pathway is also done. Arachidonic acid is done, and that basically means that all of your newly synthesized mediators are done. What are you left with? You are left with the plasma derived mediators. Plasma derived mediators में क्या नहीं पढ़ना? देखो, clotting factor pathway तो I'm not teaching you here because clotting pathway is like so much in detail we are going to study in platelet chapter, na, blood clotting chapter. So clotting pathway is very simple. Abhi I will be teaching you the kinin pathway. What is it about the kinin pathway that you have to know? Please note that in the kinin pathway, common sense lagao that when there is clotting happening, wo to alag se the intrinsic extrinsic pathway you will have, but please remember that factor 12, जो clotting pathway का factor 12 था, that is also going to activate the kinin pathway. That is also going to activate the kinin pathway, resulting in the formation of which kinin? Resulting in the formation of bradykinin. What does bradykinin do? Very, very important question of the paper. Bradykinin causes vasodilation and bradykinin causes pain. So, now tell me, what are the two things in inflammation that I have taught you for pain? Which prostaglandin? E wala sound. PGE2. E is the sound for pain, na? And the second one is going to be bradykinin. These are the two things which are going to cause pain and which are very, very, very important for you to know. So repeating, clotting pathway to pad lenge. We already know that factor 12, 11, 10, 9 wala pathway. Out of them, I'm just saying factor 12 is going to activate the kinin pathway. Which kinin is formed? Bradykinin is formed, causes pain and vasodilation. Clotting done, kinin done. Which K is left in the plasma mediators? The complement system. Yes, you will be studying the complement system in a lot more detail when you come to obviously microbiology. But whatever details you have to know here, I'm wrapping it off. So remember, when I'm talking about the complement system, we all know there are three pathways. Jaldi se let us revise. There is something known as the classical complement system pathway. There is something called lectin, or some people also call it mannose lectin. If you want to learn the full microbiology part also over here, there is also known as the mannose lectin. And the third one is the alternate pathway. So first question that comes in everyone's mind is that, ma'am, complement system so I have learned, but three pathways are also there, rat liya, everything I have done, but when do I start which pathway? How does my body get to know? Classical karna hai, alternate karna hai, mannose karna hai, how will my body get to know? So remember, whenever there is any antigen-antibody complex involved, which is going to include M and G antibodies. Antibodies M and G are there in that pathway, in that immune complex, you will start the classical pathway. If IgA is there, then common sense, A for A, which pathway will you start? Alternate pathway. And if it is to do with any bacteria, bacteria have mannose in it, na, so which pathway will you start? Mannose pathway. Repeating, if antigen-antibody complex is there with the traditional antibodies M and G, you will start the traditional classical pathway. If IgA is elevated, then you will start the alternate pathway. And if organisms are there, you will start the mannose pathway. Now remember that classical pathway starts from the classical number 1. Classical number 1. So in fact, if you want, I can show you the chart. The classical pathway, how did it start? It started with the antigen-antibody complexes, and via which one has it started? It has started from C1. Same way when you talk about the lectin pathway. Now let's talk about the lectin pathway. Mannose lectin pathway with some bacteria it started. This has started with C4 and C2. 2 and 4. This has started with 2 and 4. And when I talk about the alternate pathway, taking an alternate route because of IgA, it has started with C3. It has started with C3. So remember, the classical pathway has started with C1, mannose lectin starts with C2 and C4, and alternate starts with C3. But no matter where it started from, it is ultimately going to result in the formation of which complex right in the end? In the end, it is going to result in the formation of the membrane attack complex. In the end, it will result in the formation of a membrane attack complex, and iska composition is asked. Membrane attack complex is C5b to C9, means 5b, 6, 7, 8, 9. Up now you know in this pathway 3 aayega, 3A, 3B, 4A, 4B, 5A, 5B, everything is AB, AB in it. So can I make a list of what is the function of each? So the first question that I ask you is, which is the most common complement deficiency that can be known in humans, and your answer is C2. The most common complement deficiency known as C2. When the early complement proteins are deficient, early wale numbers, 1 to 4 wale numbers, this has been associated with a disease called SLE. SLE has early complement deficiency. It could be written like this also. Early complement systems or early complement proteins are deficient. Which autoimmune disorder can occur? SLE can occur. Coming to the next, firstly tell me what is the composition of MAC. I just told you it is C5b to C9. C5b to C9. If MAC is deficient, please remember this could be associated with capsulated organism infections. Capsulated organism infection, one example that I can give you which very commonly comes in the paper is Neisseria meningitidis, because we know that Neisseria meningitidis is a capsulated organism. So that is going to have C5b to C9 ka deficiency, MAC ka deficiency is going to result in it. Now they will ask you, what is this? And this came in the previous FMG and the NEET exam, C1 inhibitor deficiency. Please note, C1 inhibitor, what is the name telling you? C1 inhibitor, it will inhibit the complement system. Basically, it's a controller of the complement system. It's a controller of the complement system. We are saying that this controller, like I am your controller. I am trying to control you that listen, please listen to me, please study, you have an exam coming up. I'm trying to control you, trying to dictate you. So till the time I'm trying to scold you, control you, you will study. The day I stop controlling and I stop, although I don't scold, but the day I stop controlling and I stop telling you, padho, padho, you guys will be super chilled out and you will not study. Same has happened. Till the time the controller was there, it was okay. Now the controller has gone missing. So now the complement system is having a party, and this party disease is going to be known as hereditary angioedema. Very, very famous. This is known as hereditary angioedema. So you will realize that angioedema, edema kahan ho raha hai? Edema can occur around the eyes. Okay. Edema can occur around the lips. So very bad looking face I have made, but these are the areas. Edema can occur around the eyes. Edema can occur around the lips. That is okay. Cosmetic things. But what if edema occurs around the larynx? Medical emergency. If there is a case of laryngeal edema and the patient is unable to breathe after that, or there is a respiratory distress, then this is going to be a MED-EM. This is a medical emergency that has occurred because respiratory difficulty, there is stridor, there is respiratory distress that the patient is going to go under. Medical emergency, and that is the question that came in the paper. C1 inhibitor deficiency, hereditary angioedema. Now tell me, I hope everyone is clear with all of this information regarding the complement system and you have studied all of this. No concern, no confusion, done with it, because now we can move on to the next topic. All the mediators are done. Now we are open to move on to chronic inflammation, granuloma and wound healing. So tell me one thing. What is the most important cell of chronic inflammation? That I've already told you. The most important cell was macrophage. Yaad aaya na? The first slide I told you macrophage. So please remember, macrophages in every organ have been given a separate name. I could have just called them macrophages, or in other words, they are known as histiocytes. Macrophages and histiocytes are the same thing, but in every organ they are called different things. So for example, what do you call them in the brain? In the brain you have glia, na? So brain mein you're going to call them glial, microglial cells. What do you call them in the lungs, guys? Lungs mein to kitna zyada pollution, dust and all is there. So in the lungs you call them dust cells. So in the brain, because there was glia, you call them glial cells. Lungs mein there's a lot of dust, so you call them dust cells. Liver is the most important question out here. What do you call them in the liver? We call them the Kupffer cells. This question has come 1 million times in the paper and I'm not kidding. Genuinely not kidding. This question has come 1 million times. What do you call it in the kidney? Kidney has mesangium, so you call them mesangial cells. Kidney mein mesangium hota hai na, so you call them mesangial cells. What do you call them in the spleen? Littoral cells. So remember, spleen mein littoral cells milega. Spleen mein littoral cells milega. What do you call them in the placenta? Hofbauer cell, previous year question. Placenta you call them Hofbauer cells. In the bone mein osteo word should come. In the bone you call them osteoclasts. Bone, osteo, so osteoclasts. And synovium mein synovium word should come. So synoviocyte, how simple is that? So remember, in the brain, glial word should come. So microglia. Lungs mein carbon wala, pollution wala, dusty cells, so dust cells. Liver, you don't need a mnemonic, we all know Kupffer cells. Kidney mein mesangium hota hai, that is mesangial cells. Spleen has Lee-Torrell cells. Placenta has Hofbauer cells. Bone has osteo, so osteoclast. Synovium has synovio, so synoviocyte type A. All of these are going to be different name of macrophages or histiocytes in different organs. Macrophages are the most important cell of chronic inflammation. Done? Now, chronic inflammation is having a subtype called granuloma. Matlab, granuloma is a subtype of which inflammation? Granuloma is a subtype of chronic inflammation. Very, very important. This is a question that has come in the paper. It's a subtype of chronic inflammation. So in granuloma, I'm going to tell you lots of pictures. It's an image fest that is going to happen right now in granuloma. So suno. Now, the first thing that you would want to ask me is granuloma giant cell ka ma'am, tell me the components. So these are the 5 components that I have drawn for you for a granuloma. Then I'll tell you about the giant cells. Okay? So what do you see right in the center over here? Right in the center over here, necrosis. So either this necrosis could be seen or might not be seen. Matlab, there could be a caseous necrosis or there might not be a caseous necrosis. So let me tell you, on the basis of this, they say that either someone can have a caseating granuloma, means caseous necrosis is present, or someone could have a non-caseating granuloma. That means that the caseous necrosis is not present. So now let me ask you that what does TB show you and what does sarcoidosis show you? Please remember, TB and sarcoidosis dono mein dono dikhta hai. What did I say? Dono mein dono. TB shows you caseating and non-caseating granulomas, and sarcoidosis shows you caseating and non-caseating granulomas. Both of them can show you both the granulomas. Then ma'am, how will I differentiate? So no, that TB can show you both. However, in TB, caseating granuloma, because TB mein caseous necrosis is more common, na? So TB mein caseating granulomas are more common. Same way, sarcoidosis can also show you both. Sarcoidosis can also show you both. However, in sarcoidosis, the non-caseating granuloma is going to be more common. Ho gaya confusion solved? Dono mein dono. If they say, does it show you both? Yes, it shows me both. But TB shows me more commonly caseating and sarcoidosis shows me more commonly non-caseating. Sorted? Coming back. So this was the story of caseous necrosis. Now what do you see around it? I see some cells are aisa round nucleus. Some cells are long slipper nucleus. So what is that round nucleus? The round nucleus is a macrophage. Chronic inflammation hai na, to chronic inflammation is basically going to mean macrophage. So I can see a macrophage, round nucleus. When the nucleus becomes long, that is known as a modified macrophage. See kya kara? Modified macrophage. What is the modification? Look at the shape of the nucleus. The nucleus has become long. That is a modified. What do you call a modified macrophage? It is known as an epithelioid cell. Some things I've written beforehand so that we don't waste too much of time in writing, and we can cover it, explain it, memorize it, revise it, and we waste more time or utilize that time, I would say, in doing all of that, because all the writing part though we've done in the main videos. Now you have to summarize everything, do quick revision, and be able to grasp a lot of important things. कुछ भी important नहीं रुकना चाहिए. That should not stop, है ना? So now coming back, till the time the nucleus was round, I called it a macrophage. When the nucleus became elongated or slipper shaped, we called it a modified macrophage, and that is an epithelioid cell. Now on that note, please note that what else? Suddenly I say that macrophages, 20-30 macrophages fused. So I said that 20-30 macrophages fused. What do you call it? So see, if there is fusion of macrophages, I will call it a multinucleated giant cell. बहुत सारा macrophages fused. So now the macrophage story is sorted. Simple macrophage hai, round, call it just macrophage. If it gets elongated like this, you call it an epithelioid cell or slipper shaped cell, that is modified macrophage. And if all the macrophages fuse, then you call it a multinucleated giant cell. Finally, do you see that there is a blue color ka dot collar around it? What do you want to call this? That is known as the lymphocytic collar. Lymphocytic collar. Do you know which lymphocytes are these? These are T helper 1 lymphocytes. Very important question. They ask you, can you guess why? Because agar T helper 1 hoga, does it release some interferon? Socho, I just taught you interferon alpha, beta or gamma. So think. Gamma. LFT, interferon alpha, beta, gamma comes from L, F and T. So T was T helper 1, alpha, beta, gamma. It releases interferon gamma. And G for gamma, G for granuloma. It results in granuloma formation. Now you have been able to put all the 2 and 2 together that we studied. So which is the lymphocytic collar? It is Th1. And now I will ask you, if this lymphocytic collar is absent, what do you call it? If the lymphocytic collar is absent, I call it a naked granuloma, and naked granuloma is seen in a condition known as sarcoidosis. Naked granuloma. So now guys, sarcoidosis shows you what? You said ma'am dono tha, but sarcoidosis was more commonly showing me non-caseating granuloma, plus sarcoidosis also shows me a naked granuloma. Now you all know what is the definition of a naked granuloma. What is absent? The lymphocytic collar is gonna be absent. The lymphocytic collar is gonna be absent. I hope everyone is sorted with this information, done all together. Yes, granuloma over. Abhisma, one thing that I'm going to pick up and do in lot of detail. What is that? Giant cell, giant cell, giant cell. Bus. Image fest is starting. Lots of giant cells you have to do. Let's get going. Before that, answer one question for me. Structure marked in the arrow of the histopathological image. I'll extend the arrow a little so that you can see it properly. Can you tell me, they are asking you, what is this image, the structure marked, what is it derived from? So, pehle to what is this structure? Do we all agree this is a giant cell? Now tell me, giant cell was formed how? Fusion. You will say, oh ma'am, fusion, yeah, I can see fusion, but fusion of what? Was it fusion of epithelial cells like squamous epithelium and all? No, it was something else. It was fusion of macrophages. So what is your answer over here? Your answer is option C. Many people do this mistake. They have just said, acha, something was fusing. Arey, what was fusing? How can I say squamous epithelium, transitional epithelium? That has no role over here. This is totally wrong. What is fusing is actually the macrophages. Everything was about macrophages now over here. So that is going to be the answer. I hope everyone's okay for this. Now I start with the type of giant cells. The first one is everyone's favorite. It's written in front of you. It's the Langerhans giant cell. Do not call it Langerhans cell, because Langerhans is what? Langerhans is an antigen presenting cell in the skin and it's totally different. I am talking about Langerhans giant cell. And how did I identify this Langerhans giant cell? It is going to show you horseshoe shaped nuclei. It is going to show you horseshoe shaped nuclei. Can you see that arrangement? Let's draw it again. Horseshoe shaped nuclei is noted, and which condition do you see it in? You see it in a case of our country's famous disease, tuberculosis, right? No confusion. The only thing is Langerhans versus Langerhans mat karna exam. Okay? Moving on to the next one. The next one is known as two-tone giant cell. How did I identify a two-tone giant cell? I first saw the nuclei and then the cytoplasm. So when I saw the nuclei, I realized they are all round, 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 round. We call them wreath-like nuclei. They are referred to as wreath-like, round, round, round as a wreath-like. And if you look at their cytoplasm, the cytoplasm is looking very, very white and vacuolated. Aisa vacuolated wala cytoplasm hai everywhere. What does that mean? That is going to indicate vacuolated cytoplasm containing fat. That is why you see this giant cell in all the fatty conditions like xanthoma. Fat matlab which stain positive? This is going to be oil red O positive. Yaad aa raha hai? I hope you've not forgotten chapter 1 while going on to chapter 2. So remember, xanthoma is going to be all things to do with fat, oil red O positive, right? That is a two-tone giant cell. Let's go to the third one. The third one is the foreign body giant cell. Firstly, it could be any foreign body on this planet. It could be some kind of a suture material. It could be some kind of a talcum powder, any foreign body on this planet. But how do I know that this is a foreign body giant cell? Do you see any arrangement? No, it is looking all haphazard. Means that when I see haphazard nuclei spread all here and there, that's a foreign body giant cell. Easiest to identify. Moving on to the fourth one. The question that has been asked a million times in the recent exams, that is Worden-Finkelday giant cell. Worden, W ka ulta kar do. Worden-Finkelday giant cell is seen in which situation? It is seen in measles. How did I know this is a Worden-Finkelday giant cell? Please remember that Worden-Finkelday giant cell, ulta kara M, that is seen in measles, shows you both intranuclear and intracytoplasmic inclusions. Very important point. This is a very important point of microbiology actually. So when you look at this giant cell, you will realize that there are inclusions. Can you see those pink color dots in the nucleus? The pink color dots in the nucleus are what? Intranuclear inclusions. And what are these dots that you have in the cytoplasm? These are intracytoplasmic inclusions. So basically there are pink dots everywhere, guys, and that is what you need to know. There are intranuclear and intracytoplasmic inclusions. Wardenfinkelde, Ulta Kara, measles. Very important. Moving on to everyone's favorite, my favorite, teachers, students, examiners, sabka favorite. The owl eye appearance, guys, the Reed-Sternberg cell. This is referred to as the Reed-Sternberg cell, and which condition do you see it in? You see it in a case of Hodgkin's lymphoma. Na? So why did I say owl eye? You can see these two eyes. What is the color of the eyes? I say pink inclusions. The color of the eyes is pink. So there's going to be a pink inclusion that is noted. This is owl eye appearance, Reed-Sternberg cell that you see in the case of Hodgkin's lymphoma. Where else in path or micro do you see owl eye? Let me show you both the ullus and the owl eye. That is how students always come to me and say, ma'am, both the ullus came in the paper. Owl is a good sign. It's said to be a good luck charm. So when this comes in your paper, means everything's going to be well. When I talk about owl eye, this is also an owl eye, but this is a Reed-Sternberg cell that you see in a case of Hodgkin's lymphoma. And this is also an owl eye, which you see in a case of cytomegalovirus. So the color of the owl eyes is very important. If you see pink eyes, that is Reed-Sternberg cell like over here. Whereas if you see blue color eyes, this means you are dealing with a case of cytomegalovirus. So the color of the eyes has to be seen. Megalo, men are usually bigger, broader, है ना? Men are bigger, taller, broader. So megalo, men के लिए blue color. Men famous blue color. Reed and Sternberg were female scientists. So female के लिए pink color. Reed and Sternberg के लिए pink color. And cytomegalo, men are mega. So they are going to have a favorite color blue. Remember, cytomegalovirus not only shows you these intranuclear eyes, it also shows you a bunch of inclusion in the cytoplasm. It shows you both intranuclear and cytoplasmic inclusion. So was there any virus just before this that I taught you which showed you the same? Measles also showed you. So now guys, you can make a table because this is what you study in microbiology also. What will you study? Which are all the organisms which are going to show you both intranuclear and intracytoplasmic inclusion. So one of them is definitely measles and the other one is cytomegalovirus. But there is no other organism which shows you both intranuclear and intracytoplasmic inclusions. So the owl eyes are also done. Coming to the last giant cell, which actually will be very important again in microbio, and that is the herpes ka giant cell. Remember, the herpes giant cell follows 3 M's. What are the 3 M's that it follows? Multinucleation, molding, margination. Matlab, M for multinucleation. You can see lots and lots of nuclei over here. Then you will see molding. All the nuclei will be fitting into each other. So dekho, they are all trying to fit into each other. They're not separate. They're like pushing each other, fitting into each other. That is molding. And finally, what is margination? Look at the margin. The margin is always darker. The margin is always darker. So that is what you see as margination. So please remember, there is multinucleation, molding and margination. And as soon as you see these 3 M's, you're talking about herpes. So if you want to do a very quick recap, when you see the horseshoe shape arrangement, it is Langhans giant cell that you see in TB. When you see this wreath-like arrangement, fatty means you're dealing with xanthoma wala two-tone giant cells. When you see no arrangement at all, foreign body giant cell. When you see intranuclear and intracytoplasmic inclusions, Wardenfinkelde giant cell, W ka ulta, you saw it in measles. When you saw the very famous owl eye appearance, which you see in Reed-Sternberg cells, Hodgkin's lymphoma. And as soon as you talk about herpes, you are going to have 3 M's, that is multinucleation, molding and margination. That is your final table for all the giant cells. So giant cell image fest done. 3 more photos left. What are the images that you have to know for a granuloma? So firstly, I'm showing you a granuloma which is looking like a star. Where do you see star-shaped granuloma? Stellate granuloma. It is seen in 2 infections. What are the 2 infections? Cat scratch disease and lymphogranuloma venereum. It is seen in cat scratch disease and lymphogranuloma venereum. Very, 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 very important. You know this. This has come a million times. So easy to pick up because it looks exactly like a star, which is a stellate. Cat scratch, LGV. Coming to the next, this is also my favorite because it looks exactly how they're saying it. Donut. It says donut and it's looking also like a donut. Please remember, for students targeting higher institute exam, donut granuloma is also known as a fibrin ring granuloma. It's also known as a fibrin ring granuloma, and all that you have to do, donut mein se line banao. So which infection? Q fever. Donut granuloma is going to be seen in Q fever, and it is also seen with a drug which was an AIIMS 2011 question, that is allopurinol. So remember, Q fever and allopurinol, they show you donut. So donut mein se make a Q out of it. You'll always remember. Coming to the last one, Dirk granuloma. What is Dirk granuloma? You can see there are two lines, as a parallel lines with dot 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 in the center. There are two lines and there are some dot 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 in the center. This is seen in Plasmodium falciparum. I hope everyone knows this, everyone remembers this. This is going to be seen in Plasmodium falciparum, which causes which malaria? It causes cerebral malaria. So actually I realized ये जो dot 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 we had made, this dot dot dot, these were nothing but Plasmodium falciparum organisms. And what is this granuloma known as? This is known as the Dirk granuloma. So remember, this is again expected. What else is expected under this? Please note that Plasmodium falciparum ke liye I have used a fancy wala stain called field stain. This blue color stain is the field stain. I hope this is also easy part of Microna. You have learned that for Plasmodium falciparum you have used the field stain. How easy is that? Sorted. So 3 granulomas. Stellate granuloma seen in cat scratch and lymphogranuloma venereum. Donut granuloma seen in Q fever and allopurinol. Dirk granuloma is going to be seen in Plasmodium falciparum. Special stain for falciparum is the field stain. Granuloma and giant cells ka image fest is done. You can quickly solve 1 or 2 questions for me. Can you tell me the granuloma shown below is associated with which of the following diseases? Kya dikh raha hai? Can you see a nice pretty donut, tasty donut in front of you? Donut में से Q बनाया तो Q fever of course, but one drug was also there, allopurinol. Both are there in the options. Okay, what else? Coxiella burnetii. Come on, examiner is trying to make a fool of me. Q fever ka causative organism is Coxiella burnetii only, na? Who causes Q fever? Coxiella causes Q fever. So basically all 3 of them are correct. The correct answer over here automatically becomes all of the above. Undoubtedly that's the answer. Let's practice one more question. The last one is going to be this. Find the correct match. Before you go into this, can you just answer them yourself? What is this all haphazard? ये foreign body होगा. This is तो aulae मतलब Reed Sternberg undoubtedly. ये round arrangement, wreath-like, this must be the xanthoma wala, two-ton giant cell. And this is the horseshoe shape arrangement, this must be Langhans. So you will realize options C and D are almost looking same until and unless you start reading them correctly. In one of them, Langhans is written and in the other one, Langerhans is written. Did you have to select Langerhans? No. Langerhans giant cell nahi hota. It is Langhans. So this is the correct option that you have over here. See, the trick over here was selecting Lang versus Langer and you were going into all these identifications. Sometimes the examiner just wants to test your alertness, your presence of mind, your common sense. Don't mess up with your common sense in that strive for learning too much of knowledge. Keep your common sense intact. Granulomas and chronic inflammation is done. The last part that we quickly have to revise is to do with wound healing. Wound healing means what? How does a wound form? What are the vitamins needed? What is excessive formation known as? So in wound healing, the first table that you all have to know. Whenever you're talking about wound healing, this is a question that you get in surgery also. At what day, what event occurs? So I have divided wound healing in exactly 10 minutes and you will not believe, but in 10 minutes I can make you revise the entire wound healing. You have one table of the events, you have one table to do with miscellaneous factors and one table to do with keloids and hypertrophic scar. Khatam, that's it. When I'm talking about wound healing, always remember 0, 1, 2, 3, 5, 3. Can you first mark this up? 0, 1, 2, 3, 5, 3 means 0 day, 1 day, 2 day, 3 day, 5 day, 3 weeks means 21 days. That's why I made you learn like this. 0, 1, 2, 3, 5, 3. That is how you sort it. So please note, 0 day par kya hoga? Someone got hurt. If you got a scratch right now, if you get hurt right now, obviously what is going to happen is you will have a blood clot. So first 48 hours to 0, 1, 2 mein to blood clot hi rahega. Correct? But first day only a blood clot will form. What is a blood clot made up of? Blood clot is made up of platelet and fibrin. Blood clot is made up of platelet and fibrin. Okay, first only blood clot will be there. Then what do you think? In 48 hours, what is the cell? Acute inflammation, hai na? 48 hours is acute inflammation. What is the cell of acute inflammation that we have? The cell of acute inflammation is going to be neutrophil. So on day 2 also the cell of acute inflammation shall be neutrophil. Simple. So neutrophil on day 1, neutrophil on day 2. The difference kya hai? Day 2, guys. All of us are guilty. I am also guilty of doing this. Whenever I get hurt or a scratch, there's a very thin layer first that comes, and then I feel itchy and I scrape it and I scratch it off. Have you also done that? And then parents keep scolding us that don't scratch it, otherwise it will leave a scar, it will leave nishan reh jayega. Yeah? All your parents must have told you that. So same way, I am also guilty of doing it. But that day 2 pe, that is known as a thin epithelial layer. A thin epithelial layer is going to come on day 2, and all of us are guilty of peeling it off. Okay, so 0, 1, 2 is done. 0, 1, 2 is done. It's acute inflammation. Now let's go into the 3, 5, 3. So here you have day 3, day 5 and week 3. So day 3 is the starting of everything. If they ask you, when does granulation tissue begin? Day 3. When does collagen begin? Day 3. Everything begins on day 3. But please remember, granulation tissue becomes maximum when it becomes maximum on day 5, and collagen becomes maximum when collagen becomes maximum on the day 21. Maximum collagen is seen on day 21. So repeating, everything begins on day 3, but granulation tissue becomes maximum on day 5 and collagen becomes maximum on week 3. What is the change in collagen? Please remember, initially the collagen that is there is collagen type 3. And at the end of this entire process, the collagen that it changes to is collagen type 1. And why does this change happen? Because collagen type 1 is the strongest collagen that we have. My body says, I want the strongest collagen. So starting mein to it was collagen type 3. In the end, it is collagen type 1. And there was a question that came 2 years ago that at the end of this entire process, what is the ratio of collagen 1 divided by collagen 3? So dekho, normal at the end, which is predominant one, end pe first is predominant one. So remember, it's 4:1, directly reference Bailey and Love surgery textbook. So just in case you see any discrepancy, you know what to quote. In the end, collagen 1, the strongest one is there and 1 is the most predominant. The ratio becomes 4:1 overall. So now tell me, is this simple 0, 1, 2, 3, 5, 3? If I just ask you, when does everything begin? Granulation tissue, collagen, everything begins on day 3. Very important point. Now they will ask you quick questions. Do you know what factors and vitamins promote healing? Remember, vitamin C is very important and zinc is very important. Very important information that you have over here. Vitamin C and zinc tablets are given so that patient can have better healing. Next, what are the factors that will delay the healing, which will not let healing occur? Lots of factors. You must have seen diabetic patients don't have a good healing. Hai na? Patients who are on steroids don't have a good healing. So diabetes ho gaya, steroids ho gaya, they don't have a good healing. The healing will happen after many, many weeks. But if they ask you what is the most common cause of delayed wound healing, your answer is going to be infections. That is why we say now, when you as an intern, you go to the ward and they say, dressing karo, do the dressing every day, change the dressing every day, don't let the wound get infected, be very, very cautious, because if the wound gets infected, the healing is going to be delayed a lot. You don't want that to happen. So the most important thing, keep the wound clean. Do not let it get infected. Last, when will the person come back 100% to normal? What is going to be the 100% strength? And ye to mera favorite answer. Sabka favorite answer. 100% strength is never going to be regained. This question, I don't know why they ask you, but they ask you a lot of times in the paper. 100% strength is never regained. Now, the last part of wound healing is left is, what if someone has wound healing and that healing keeps on happening? Excessive amount of wound healing happens. You say 2 scenarios, ma'am. Number 1 scenario is excessive amount of granulation tissue bana. Too much of granulation tissue. When does granulation tissue formation start? Day 3. And after that, granulation tissue kept on forming for 20, 30, 40 days. That is known as proud flesh. Why? Because proud for the color that it has a red color. We know granulation tissue is extremely vascular. It has a lot of blood vessels. So when there will be too much of granulation tissue, that area is going to look very what? It is going to look extremely red. How are you going to treat it? You are going to treat it by cautery. If you have to treat this, you will remove it by cautery. So that is excessive granulation tissue. Remember this word, proud flesh, very important. They just ask you, what is proud flesh? Proud flesh is granulation tissue. What if on the other hand, there is excessive scar formation? What if on the other hand, there is excessive scar formation, and scar formation can be of two types. Either it's going to be a keloid or a hypertrophic scar. So let's quickly look at their pictures. Either it's going to be a keloid, as you can very well appreciate over here, है ना? You can see the location, the sternum, and after an ear piercing, तो कोई trauma होगा. What is the most common site? Of course, the most common site is going to be the sternum. The most common site is going to be sternum. So now, for example, there was a trauma and it occurred on the sternum, or someone had an ear piercing, nose piercing, कोई piercing हुआ and that person had a keloid. How are you going to treat it? The question that has come again a million times. Don't cut it off with your scalpel. Don't surgically remove it. This is anyway happening because of trauma. Why do you want to give more trauma? Give steroid injections. Shrink the colloid. What are you going to do? Inside this, you will give an injection. Intralesional injection. You're going to give an injection of what? Of a steroid. Triamcinolone is given. There's an injection of triamcinolone that is given, and that is going to do what? That is going to shrink the keloid. That is going to shrink the size of the keloid. So everyone understood questions on keloid. Most common site is sternum. Treatment is intralesional injection of triamcinolone, which is a steroid. The other one that you have over here is a hypertrophic scar. Hypertrophic scar is usually self-limiting. It is excessive, but it is usually self-limiting. You don't need any treatment. अपने आप ठीक हो जाएगा. But if you ask me, how are you going to look at these two under the microscope, ma'am? So this is the picture that you have of a keloid, and this is the picture of a hypertrophic scar. In a keloid, you can see these blue bundles, very thick, and one is going left, one is going right, one is going as a vertical, horizontal. So can I say there are haphazard collagen bundles? In keloid, it's a mess. There are haphazard collagen bundles, and you can see they are going in any direction. Your blue color lines are going in any direction. Whereas in hypertrophic scar, they are all arranged in a nice single direction. There is orderly collagen fibers. There are orderly collagen fibers that are noted. So repeating, the difference between a keloid as well as a hypertrophic scar is keloid में it's a total mess, ऐसा left right haphazard. Hypertrophic scar में it's going very much in order. But how did they look at these collagen fibers? What is the stain that I have used? Mason trichrome. Trichrome, 3 color. Trichrome means 3 colors. So remember that the first color that you have is going to be red. The second color that you have is going to be blue, and the last color that you have, which you can hardly see on this text, must be blue-black. Almost dikh hi nahi raha hai na? That is why I've written it purposely like that. So there's a red color, a blue color, and a blue-black color. Blue-black color bhul jao because that is nucleus. That is why I'm writing it so that you can hardly see it, because you don't have to learn it only. Nucleus, so every cell has. I'm not interested. That is blue-black. I am interested what is red and what is blue. So one of them is going to be muscle, and one of them is going to be collagen. So learn any one of them. Mr. Muscle is going to be red. So collagen will be blue. Over here I'm seeing all blue. Here also all blue. Matlab, what is this? This all must be collagen. Collagen is going to be blue. Collagen is going to be blue, and Mr. Muscle is going to be red. So whenever I have to differentiate between muscle and collagen, what is the stain that I use? I use the Mason trichrome. I hope you are not confusing it with Mason Fontana, because Fontana was tanning of the skin. That was for melanin. Read the question carefully. Have they given you Mason Fontana or have they given you Mason trichrome? ठीक है?